Good evening, everyone, and welcome to the AIOS Scientific Committee Cornea Case Files International Stars. I wish to welcome each one of you who are viewing the Cornea Case Files today, our panelists, our honored speakers, and our international faculty. So I'd like to introduce to you our wonderful international faculty. And the first is Professor James Shadosh, Associate Director, Infectious Disease and Vice Chair of Education, Harvard Medical School, Boston, USA. Dr. Chadosh is a clinician scientist, internationally known and respected for his molecular virology, the viral genomics, viral pathogenesis, in addition to serving as Associate Director of the Cornea Surgery Services. He directs Boston Keratoprosthesis Program and serves the Chair for Ophthalmology Education at Medical School and Associated Chief of Ophthalmology Education at Mass Eye and Ear Institute. His clinical interests include ocular infections, chemical burns, Stevens-Johnson syndrome, and keratoprosthesis surgery. Welcome, Professor James Chadosh. I have great honor to also introduce Professor Elmer Tu, Professor of Clinical Ophthalmology, Director Cornea Services, Illinois Eye and Ear Infirmary. Professor Tu specializes in infectious diseases of the cornea, is widely viewed as his expertise in the diagnosis and treatment of Acanthamoeba and other severe infections of the cornea. Professor Tu's area of expertise also includes new and innovative forms of cornea transplantation and treatment of challenging ocular surface disorders. I have great pleasure to introduce our own Professor Mahipal Singh Sajdev, President AIOS, Chairman Scientific Committee of IRSI, Chairman and Managing Director of Center for Sight, Group of Eye Hospitals. I have the great pleasure of introducing Dr. Quresh Muscati of Muscati Eye Clinic, a cornea specialist, past president of All India Ophthalmological Society, Maharashtra Ophthalmological Society, and Bombay Ophthalmologists Association. Dr. Virendra Sangwan is Director Innovations of Dr. Shroff's Charity Eye Center, New Delhi. Thank you, sir, for coming on. Professor Jeevan Singh Tatyal, Professor and Head of Cornea, Cataract and Refractive Surgery Services at RP Center, Ophthalmic Sciences, AIMS, New Delhi. Professor Namrata Sharma, Secretary AIOS and Professor of Ophthalmology, Cataract, Cornea and Refractive Services, Dr. RP Center for Ophthalmic Sciences, AIMS, New Delhi. And I request our President, Professor Mahipal Sajdev, sir, to welcome each one of you. Over to you, sir.
Thank you very much, Dr. Partha. Good evening, everyone, and good morning to dear colleagues from US. In the first instance, I'll wish to warmly welcome Professor Shadosh and Professor Elmer to this webinar, which is on cornea case reports. And I would also take this opportunity for the help that was given to us in formulating the guidelines for restarting the practice by AIOS by Professor Shadosh. And we did get a lot of information regarding aerosol generation, etc., in cataract from him. So I think we have a galaxy of speakers who will be presenting difficult cases or how they manage, and obviously there will be some areas of gray which we'll be looking at as to whether the correct way was done or there were some other ways and things like that. And I think the panelists are all great cornea people. And having subsectional specialty-wise case reports is something that Partha has brought about in this particular webinar, which he hopes to continue going on to further such case series. So I think welcome to all the delegates who are listening, those who have interest in cornea as also otherwise, all the panelists, all the speakers, and especially the international faculty and members of the scientific committee who have put this together. I think Dr. Somshila has been significantly instrumental along with Dr. Parikshit And I see Dr. Amit and Dr. Feroz also, so Dr. Sonu is also there. So I think all of you have, and Dr. Balla is also there, I think. So I think you have all put this together, and let's hope to have a great interaction, panel discussion. And without much ado, I think Partha, over to you, or Shomshila, whoever would want to start. Thank you.
Over to Somshila, please.
Thank you very much, Dr. Partha. Thank you, Dr. Maipal. This has been, it's like a dream come true to have these many international and national stars in one meeting altogether. And of course, everybody knows that the subtopic is corneal infection, which we are battling with. And everybody was very challenged during this COVID times also to handle these infections. So we have a potpourri of very interesting cases and keynotes by, as was already introduced, by international star faculty. So we'll start off by having the first case presented. Before that, we'd like the first speaker to be introduced. The first speaker is Dr. Rishi Swarup.
Good afternoon. Dr. Rishi Swarup needs no introduction. So he's a young star himself, and he's a medical director and chief surgeon at the Swarup Eye Center, Hyderabad. He has numerous achievements and awards to his credit, and I think we'll hand it over to him and hear from him. Over to you, Dr. Rishi.
Thank you, Dr. Parikshit. At the outset, I'd like to thank the AIOS Scientific Committee and particularly Dr. Somshila for involving me in this first webinar from the Scientific Committee, and it's good to be in such august company. I'll just get started with my case. So it's an interesting case which I had managed a few years ago, and Dr. Somshila wanted me to present a case on this topic, so I selected this one. Just one second. Yeah, is my slides visible?
Yes, yes, it's visible.
Okay. So this was a 65-year-old female patient who presented to my clinic in November 2011. She was a case of advanced rheumatoid arthritis who was already on systemic treatment with recurrent episodes of corneal melts in the past. And she had also presented with complaints of history of viral keratitis in the past, which was documented. And she had, came to my clinic with complaints of blurring and burning of eyes. And she had all the classic systemic features of rheumatoid arthritis, the hand deformities, and both multiple joints of upper and lower limbs, and also had dryness of mouth. Her vision was 6/18 in the right eye and 6/9 in the left eye. And she had a few SPKs in the right eye and a lot of SPKs in the left eye with peripheral thinning. Surprisingly, the vision was better in the eye with more SPKs. At this point, I don't remember why that disparity was there, but this is what is documented in my file. The Schirmer's was 4 millimeters in the right eye and 1 millimeter in the left eye, Schirmer's 1, and the rest of the ocular examination was within normal limits. So the patient was put on preservative-free lubricants and topical cyclosporin, and was referred to the rheumatologist to look at her systemic status. And over a couple of weeks, she improved and she became comfortable and was asked to continue drops. Of course, I gave her the option of punctal occlusion, etc. But then the patient came back in December with decreased vision and redness of 2 days duration. And she had an atypical epithelial lesion, like a heaped up epithelium with the underlying stromal infiltration and edema, which kind of looked like somewhat like a viral keratitis. Her corneal sensations were also reduced. And since she had a past history of viral keratitis, I made a provisional diagnosis of viral keratitis, but the differential diagnosis of a rheumatoid melt. I started on topical antiviral, but also started on steroids because she had an active stromal infiltrate, along with the lubricants, of course. And she responded to this treatment and resolved within a week. Then again, in the subsequent year, March, July, she came for a routine follow-up, and she was doing okay, and her vision also had improved in the left eye. So she was on topical lubricants and cyclosporin. Then in September the same year, she came with another recurrent dendritic keratitis, which was treated with topical antivirals. And then she got okay. At this point, I started her on a prophylactic oral acyclovir 400 milligrams twice a day also. And then the patient got back to her old status and she was doing okay. And again, 1 year later, after this was September, and then August 2013, she presented with another acute episode with drop in vision, and she had an inflamed eye with an acute corneal melt. This time it was looking more like a rheumatoid melt. This patient was essentially put on steroids along with lubricants. And of course, I sent her back to a rheumatologist to step up her systemic treatment. And she again stabilized. And for over a year, she was okay. Then in Jan 2015, she came with a drop in vision in her left eye. And right eye pretty much looked the same, but left eye basically showed an increased cataract. And rest of the findings were pretty much the same. She had a stable ocular surface. And of course, there was the old scar and thinning from the last episode of melt and also the previous scars. The topography showed a fairly regular astigmatism, which I'll be showing later. So since I was planning a cataract surgery for this patient, I decided to go with a toric IOL. This is what the patient's cornea looked like. You can see the scarring, and there's a lot of thinning with vascularization, almost 80-90% thinning, as you can see in these images. And the cataract was about grade 2 nuclear sclerosis. You can see on the OCT that area was, the stroma was quite thinned out in the area of the scar. And the topo, you can see that there is some irregularity, but there's not much of skewing of the Myers. The bow tie is pretty much in line. So I found that these patients often do well with toric IOL. So that's what I decided to do in this particular case. I'll show you the video later when we are discussing. And of course, there were some challenges with visualization, but we managed to safely implant the toric IOL in the desired axis. I used a Technis toric IOL because that was pretty much correcting what I needed to correct in this particular case. And this is how the patient looked. The first postoperative day, you can see that the IOL is in place. And luckily, the vision was pretty good, 6/9 unaided, improving to 6/6 parts. And you can see that the IOL is perfectly aligned with the planned axis that was desired. And subsequently, this patient also underwent right eye cataract surgery. The right eye was the better eye in 2017. And even 4 years later, the patient maintained pretty much the same cornea with similar visual outcome. So just to show that even in challenging cases, one can use toric IOLs and get a good outcome. So there were a lot of points to discuss in this case. One was, how does one differentiate a rheumatoid melt versus a viral keratitis? And are these two conditions described in literature to be associated? Whether topical and systemic immunosuppression would have predisposed to the viral recurrence, and what should one be doing in such cases, including the systemic immunosuppression and topical cyclosporin. Cataract surgery in such eyes with bad surface, scars, what should one do? When is it the right time to operate? Should one put temporary plugs before doing surgery? What is the role of prophylactic acyclovir and how long should one give it in such a case? Biometric challenges, etc. How to select the toric IOL, etc. So I think all these points can be discussed, and I'll now hand it over to Dr. Somshila to take it forward.
Thank you, Rishi. I think that was an excellent case. Actually deserves a round of applause. You managed it so well.
Thank you.
And as you said, there are lots and lots of discussion points. Probably we'll ask Professor Titial and Professor Sachdev to start with your last 2 points first, actually. So let's start about their experience, and I'm sure they had plenty of it. How do they approach such a case, especially surgery in such scarred corneas? And this was a choice for toric IOL, and the patient did extremely well with that lens. And what would their choice be? So how would they approach, and what would their choice of lens be? So either Dr. Titial or Dr. Sachdev.
I'm just going to let the surgery video run in the background as we discuss.
Yes.
Okay. So basically, I think I would beg to differ slightly as regards the choice of a toric intraocular lens. Rishi has been reasonably lucky that there has been no recurrence of any episode, whether of the rheumatoid melt or the viral keratitis, because both these diseases are known to keep on coming back. So at any particular time, if you are looking to do a toric intraocular lens, if at a particular point you are having what you said was a regular kind of an astigmatism, though if you look at the OCT, there was a gross thinning, and even the slit lamp picture showed a gross thinning. The key point was that it was slightly off-centered. So in case a person gets the recurrent episodes of either of the two things, under those circumstances, instead of doing good to the patient, it could, and if the axis of the astigmatism shifts under those circumstances, it could actually do slight harm. So this is maybe because you are 15-20 years younger to us. So this is a slightly aggressive approach in my opinion, because the basic thing that you want to do in ophthalmology or in any field of medicine is do no harm to the patient. So I would be slightly conservative, because the IOL power calculation with the keratometric readings not being accurate, I'm sure if you looked at the keratometric readings, they must have been different between a manual keratometer, auto ref K, or an IOL master, or a topography. So getting to the right power in any case is going to be difficult. You were lucky, but I don't think I would wish to convey this message to the people around, that you should go ahead with such scarred corneas where there is always a possibility of the disease progressing and having recurrence of viral keratitis with a toric intraocular lens. I would rather leave the patient with a monofocal lens. Obviously, you got a great surgery done. And as was pointed out for you, by you, I would first want to smoothen out the surface. Punctal plugs definitely I'll wish to do, because the Sherman's was pretty bad. And limited use of topical steroids, maybe not give any NSAIDs in the post-op period, and give extensive amount of lubricants to this patient. So that is what I would wish to do, and I would maybe take multiple readings on different instruments to get to the keratometer, and I would prefer to use an optical biometer for doing the axial length. So I think that's my take on this particular case.
If we can just go on to Professor Titial, since we have discussed about the surgical aspects, I'd like to actually ask you regarding 2 points. One is that the patient had epithelial keratitis with HSV during the course of one of the follow-ups. And Rishi's very valid point was that what is the association between the two? So could you just talk about that part of this case?
I think this was a little unusual presentation of two pathologies in a one patient. And I would definitely agree with the diagnosis of, poor ocular surface because of rheumatoid arthritis, which was very clearly visible in this particular case. And the history of previous viral attacks, recurrent attacks, would also go in favor of that. So both can coexist as a separate entity in this particular case. The patient would have had a case of viral keratitis, recurrent viral keratitis to begin with. But subsequently, patient had the consequences, sequelae of rheumatoid arthritis in this patient. So both would be there, and they have to be managed separately whenever they recur into patient's ocular surface. I think the initial management when it came to Rishi would have been the case with the poor ocular surface because of rheumatoid arthritis. And the management was based on the ocular surface finding, that is basically SPKs and poor Sherman's in that particular case. I think that initial phase, he started her on the lubricants as such, and improving the ocular surface with cyclosporin at that particular stage, and patient did well. I think that stage I would have added the steroid to begin with, because patient had a SPK in both eyes, and there was no evidence of viral keratitis, and that would have given before actually cyclosporin getting the actual effect of cyclosporin, because it will take 4 to 6 weeks for cyclosporin to act. So this surface acting steroid would have given a much better stability for ocular surface, and subsequent problem could be handled. So as far as association, I think both can be there.
Right.
And subsequently, patient was lucky that didn't have the peripheral melt getting worsened, maybe because of better systemic management of this particular case. The lesson to learn in these cases is if you have both things together, the ocular surface staining would be done appropriately. Maybe use rose bengal or Lissamin green to say if actually it is a dendritic viral onset or is a pseudodendrite or picture, which can happen with these type of cases sometimes, and that can mislead you. And if you start antiviral on the surface, that can deteriorate the condition also. So
no,
that have to be
typical
effectively
dendrite. This was the typical HSV dendrite with
and
terminal
if patient
bulbs.
improved on your treatment, that shows
Yes.
that patient did have this thing. But people who are not into a corneal practice, they have to really do a good staining and see and differentiate pseudo versus the actual dendrite, then initiate the treatment for these patients. And you did a wonderful cataract surgery also. And I think if you want to give a systemic ACVR for these patients as a prophylaxis, then you have to give at least sort of 6 months to 1 year to have some sort of effectivity.
I think, Somshila, there was one query that was there, and that was that melt is because of viral keratitis, or is it because of the rheumatoid?
She wanted to just answer that quickly before we move on. The melt is viral keratitis or due to the...
So the melt was definitely rheumatoid.
Rheumatoid. So I thought as much, because viral will incite a lot more vessels as compared to rheumatoid melt, which will be little avascular, which is being seen in this case.
And Dr. Mahipal was right, the rheumatoid is a progressive disease, and your ocular surface and the topography will keep changing for such patients.
Even viral,
more, even viral also, you're right, Namata.
Recurrent. So if the patient has more episodes, then the curvature, may change.
Thank you. I think the very valuable points. Thank you, Rishi, for presenting such a wonderful case. I just know that this patient will do well in your hands. And thanks, Dr. Titya, Dr. Mahipal, Dr. Namrata. So that is setting the stage actually for our next speaker. And we welcome Professor James Chodos. Already you've heard the introduction, but for those who joined in late, Dr. Chodos is probably one of the most well-known names in ophthalmology at this point in time, especially during COVID era. And we'll go on to his talk. He's going to talk about HSV for us.
Thank you. Can you see my screen?
Yes, we can.
Great. So thank you. It's a really pleasure to be with all of you. I wish I was with all of you in person instead of on Zoom, but this is the world we live in for the near future. So I was asked to talk about herpes simplex virus keratitis. Excuse me. I have no interests, financial or otherwise, relevant to this presentation. This is a case that I thought I'd start with. It's a 20-year-old woman who came in complaining of a red eye and a sore throat. And this is the back of her throat, pictures that we took in clinic. And you can see on the right side of her throat, these vesiculopustular lesions. This is an image of her ocular surface. And I think your attention will be drawn immediately to the coarse dendritiform lesions in her corneal epithelium, maybe a suggestion of terminal bulbs in a few of these, but I would also bring your attention to these eyelid margin ulcerations. Herpes simplex virus type 1, or human herpes virus 1, is an enveloped double-stranded DNA virus, and it's said to be the leading cause of infectious corneal blindness. At least that's what all the grant applications say that are applying for research funding on this disease. There are numerous ways to make the diagnosis, but practically speaking, they're only useful for epithelial keratitis, and for almost all of those cases, the diagnosis can be made clinically. I would note that a common error still, at least in the US, is to send for serology, and unless the patient is very young, serology is rarely helpful because infection is so ubiquitous. Herpes simplex virus type 1 can cause infection of almost any eye tissue. I've never seen a lenticular infection, but anywhere else you can think of in the eye can be infected by HSV1. And this is the images of that young woman. Again, for our own interest, we both cultured her and sent for serology. She was 20 years old, and the culture was positive for HSV1 from the eyelid margin. And the serology showed a positive immunoglobulin M. And this was a primary infection, which we later came to believe was sexually acquired in this young woman. So I want to focus a bit on the classification of this disease, because I think we've identified over the years a lot of confusion about HSV keratitis. And I believe that confusion comes about principally because there's so many manifestations, and these varied manifestations have very different names, and those names vary by region in the world, such that it's even difficult in some cases to interpret the literature with regard to the disease. And we've advocated very strongly for an anatomical classification system that any eye care provider who knows how to turn on a slit lamp should be able to do. And that would divide the disease into epithelial keratitis, stromal keratitis without ulceration, meaning epithelium intact, epithelium not intact, and endothelial keratitis. Epithelial keratitis sometimes is punctate, linear, but most commonly dendritic or geographic. Stromal keratitis without ulceration has been called interstitial keratitis, non-necrotizing, or immune stromal. I've always objected to the last term because it implies that other forms of herpes keratitis don't involve the immune system, and that's not correct. Stromal keratitis with ulceration, also known as necrotizing. Necrotizing inflammation is something that pathologists can call, but as clinicians, when we use the term, we like to use that term, but it's not really appropriate. And finally, endothelial keratitis, which at least in the US and I believe in India is often referred to as disciform keratitis. But interestingly, in Japan, the use of the word disciform is with stromal keratitis without ulceration. So there's one example of where the terminology, because it's anachronistic, is confusing. So really what this requires is that you look at the cornea with the slit lamp and determine where the greatest degree of involvement is. This has been codified in the Academy-sponsored clinical guideline that we published some years ago, which I'll mention again. This classification system is not novel. In fact, Leopold and Siri proposed an anatomical system like this back in 1963, and I'm sure if we looked hard, we could find prior examples of this sort of anatomical approach. So what you really need to do to classify it is to pay special attention to the layers of the cornea and also the anterior chamber. And the goal of this is to be able to go from a simple classification to a treatment algorithm. Without that, the treatment algorithms are very confusing. So in this scenario, if you're cloud gazing and you see one that looks different, and in fact, it looks like a falling airplane engine, maybe it is. Maybe you should get out of the way in that case. This is epithelial keratitis. And you see here the geographic components in the upper part of your slide, beautiful terminal bulbs at the lower part of your slide. And very commonly, there's a mixed picture. Geographic epithelial keratitis where the basement membrane has been laid bare, and dendritic keratitis, not so much. This is a slide from Kirk Wilhelmus showing HSV lytic antigens in the corneal epithelium, and epithelial keratitis is literally an infection of the corneal epithelium. Here it is stained with lissamine green, which beautifully stains both the edges and the stromal base. Fluorescein, which stains better the base. Rose bengal, which stains only the edges. And by this point, you can see the patient is getting dry from all our staining. This is not epithelial keratitis. This has been called a ghost or footprint. It's what you see at the last stages as the epithelial keratitis is resolving or is just resolved. It's a subepithelial haze that takes on the shape of the dendrite. And this does not require treatment. These typically resolve on their own. And I'll show you in a moment a case where I, in my younger years, treated one and created a problem for the patient. This is stromal keratitis without ulceration. These literally look like nebulae or clouds in the corneal stroma, and they can occur at any level of the cornea. You can see superiorly deep, full thickness, and superficial involvement. Here's another case, and they're very commonly multifocal, and they literally do look like clouds floating around in the cornea. They can be denser though when they're more active. And here I think you can see very nicely how well demarcated they can be by level. They can be only in the posterior cornea with a very sharp demarcation line, almost like the person has had LASIK. They can be mid-stromal, anterior. There's really no rules about depth location, and it's very common to see them at various depths and various locations. This, on the other hand, is stromal keratitis with ulceration, and I haven't stained this, But if you can see my pointer, the outline of the epithelial defect is here. They're very strong inducers of neovascularization. They very commonly occur or start in the periphery and can confuse you in that they are a form of peripheral ulcerative keratitis when they present in the periphery. They characteristically march toward the center of the cornea when treatment has not been appropriate. They leave behind a thinned, deep, densely vascularized cornea, and they will cross right into the visual axis while you're watching them or perhaps treating them as if they're microbial, not considering a herpetic source. So these are the ones that are most commonly misdiagnosed. This was the patient I mentioned who had an epithelial dendrite, had a ghost subepithelial stromal opacity as they were resolving. I thought, maybe I should treat that with steroids. They developed this geographic epithelial keratitis that you can see outlined with rose bengal. I quickly withdrew the steroids and induced a rip-roaring stromal keratitis with neovascularization, all of it preventable. Had I just cooled my heels and relaxed, it would have just all resolved. So don't make that mistake. This is endothelial keratitis, and in this situation, the stroma has very few white cells. The inflammation is targeted at the corneal endothelium, and I think you can see these large keratic precipitates with overlying very well demarcated stromal edema with epithelial microboli and microcystic edema. Here's another case. This is HSV endothelial keratitis, and you can see what looks like a Coude-Douce line, but this patient has never had a corneal transplant. The problem with calling this disciform keratitis is that sometimes it's diffuse, and when it involves the whole cornea, it's the same process, but it's not disciform. That's difficult to make the diagnosis because you can't see the anterior chamber in that case. Your only clue sometimes is an elevated intraocular pressure, which would be characteristic of a herpetic infection. The reason I asked you to look not only at the layers of the cornea, but also the anterior chamber in all cases, is because you might confuse this with a keratouveitis. In keratouveitis, the inflammation is targeted at the uvea, and you get spillover with a bathtub ring of precipitates on the cornea. But the anterior chamber response is the major site of inflammation. So you will have 2 to 3 plus cell in the anterior chamber and some keratic precipitates. In HSV endothelial keratitis, there's a paucity of anterior chamber cell. You may see no cells or trace cells, but yet you see these very impressive keratic precipitates. And that's how you make the diagnosis of endothelial keratitis as compared to a keratouveitis with endothelial keratic precipitates. Okay, there are some special considerations in HSV keratitis. There's atopy. It's said that HSV is more common in atopes, more likely bilateral and more likely recurrent and harder to treat. And all of these are based on case series, but I believe them based on my personal experience. If you look at the literature, it says that 5% of HSV keratitis is bilateral. In my experience, almost all of the bilateral cases have had the triad of atopy. This was a case in point, a patient with bilateral lid margin ulcerations and a coarse epithelial keratitis. This patient was asthmatic, and he presented with his first case of epithelial keratoconjunctivitis and blepharitis. What about following penetrating keratoplasty? It's almost always epithelial, not always, but usually. And that's because these patients are typically on postoperative corticosteroids, which, as we know, can enhance or enable epithelial infection by the virus. And it should always be an indication for oral prophylaxis. Personally, I tell patients planning to have surgery with a history of HSV keratitis that they will be on oral antiviral prophylaxis for life. And that's because we don't really have any clinical data suggesting when it's safe to stop. This is a patient. Elmer will recognize this slide. It's from the Bascom-Palmer slide set. It's a patient with a corneal transplant on corticosteroids who developed a largely geographic but partly dendritic HSV epithelial keratitis stained here with rose bengal. What about quiescent disease? You can have non-healing epithelial defects. We would characterize them typically as neurotrophic keratitis. They used to be called metaherpetic, stromal scars, vessels, lipid keratopathy. And if you don't treat endothelial keratitis promptly and properly, you can have permanent damage to the corneal endothelium and have persistent corneal edema that lasts for the lifetime of the patient unless treated. This is a 13-year-old who never received proper treatment, came to me with a quite poor vision with extensive lipid keratopathy. I believed at the time this was all avoidable. This is a patient that was sent to me by a corneal specialist who had never received oral acyclovir, had a graft for HSV keratitis, and had repeated episodes of stromal keratitis with ulceration that were here marching toward the center. And I'll return to this case toward the end of my talk. We set out quite a few years ago to look to see what was the evidence-based foundation for the treatment of HSV. And I'll not bore you with all of this, but what we found was a lesson in clinical trial history in that only the herpetic eye disease study trials, which I'll mention again, used proper methodology in which they calculated sample sizes a priori or prior to starting the trial and were properly powered. So only the head studies could really be looked at as level 1 evidence. I know you can't read this. These were the epithelial keratitis trials that we found at the time. These were trivial to me, and I was shocked to see how many there were, because no therapy for HSV keratitis really does much more than shorten the course by a couple of days. And epithelial keratitis, unless the person's immune suppressed or on corticosteroids topically, will resolve without treatment. On the other hand, the stromal keratitis studies were more interesting. Back in 1983 and then in 1992, there were 2 studies of betamethasone showing that it was better than placebo when given topically in the setting of topical acyclovir. And then the famous herpetic eye disease study, first authored by Wilhelmus, that showed that prednisolone, given in the context of topical trifluridine, which was the topical agent available in the US at the time, was better than placebo and trifluridine in treating stromal keratitis over a 10-week course. Importantly, and I think the most important findings from all of the head study was the acyclovir prevention trial, which showed that 400 milligrams twice a day of oral acyclovir reduced the rate of recurrent HSV stromal keratitis by about half. So not to zero, by about half, and that will come up in a moment. So these were prospective clinical trials, multi-arm, double-masked, multi-center, funded by our NIH. And you could summarize them as saying for stromal keratitis, corticosteroids treat and acyclovir prevents. The studies also showed that adding acyclovir to a topical agent, adding oral acyclovir to a topical agent when already treating with corticosteroid was of no additional benefit. So multiple antivirals don't really help you, and that you can't use antivirals to prevent recurrence. In a patient with epithelial keratitis, adding an oral antiviral doesn't prevent recurrent keratitis later. But if you study clinical trials, you'll see that in order to get to an interpretable outcome, you need to have a clear question. And clinical trials, when they have a finding, often lead to new questions which were not answered by the trial. So we learned that topical steroids with a prophylactic antiviral work for stromal keratitis, and that oral acyclovir is no additional benefit when treating topically with an antiviral and a corticosteroid. But the question remains, would there be an advantage to use of an oral agent instead of a topical agent for stromal keratitis when treating with corticosteroid? We know that long-term acyclovir reduces the rate, but we don't know who should receive it, and we don't know how long, as was mentioned. We also don't know whether an increased dose or a different oral antiviral agent would be more effective in prophylaxis. No one has ever studied these in a randomized clinical trial. And another question comes up is, would an infrequent low-dose topical corticosteroid further prophylax patients against recurrence? There's some evidence from surveys that we performed that corneal specialists like to add an infrequent or low-potency corticosteroid to their prophylaxis. But again, that has never been studied. One of my interests has been how to diffuse information, for example, from the herpetic eye disease study into clinical practice. All of you on the panel, at least, are corneal specialists, and all of you know that you see patients who come from outside who are referred in which the treatment that you would rather provide may not have been given. So how do we deal with that? It turns out that if you study across the board, there's a 17-year lag between the introduction of new information and its full implementation into clinical practice. How do we speed that up? Well, courses like this, but this has limited reach. In the US, we have recertification exams, but you could get every question on HSV keratitis wrong and get all the macular degeneration questions right and pass this test. We have in the US scope of practice restrictions telling what specific eye care providers can and cannot do, but these are regressive and haven't been shown to actually improve care. In some cases, they restrict bad care, but they don't seem to be improving care. We also have financial means through Medicare started to reward us for evidence-based care, but they quickly became penalty-driven. So now we're penalized if we can't show that we have followed evidence-based care. And I object to regressive measures personally. We wrote and published this clinical practice guideline, which very few people look at because it's time to do that. I personally believe that the future is bright because as we develop electronic medical records that are actually intelligent and actually learning tools, we can, as you enter clinical findings, for example, the electronic medical record could lead you to a differential diagnosis. And once at that differential diagnosis, the electronic medical records could suggest treatment algorithms that are evidence-based. So the trainee in the future, if they're able to do the examination, and obviously we would still need to do an examination, or perhaps we'll have digital photography reading those exams and telling us what to do, and maybe the patient can get their treatment from home. But in the near future, electronic medical records have huge potential to improve evidence-based implementation. And then we're learning a lot in the US from the IRIS Clinical Disease Registry. Over 70% of US ophthalmologists are now contributing data. There are huge numbers of patients whose data is in this registry. And we can learn a lot outside clinical trials with this data. So I'm cautiously optimistic that this 17-year odyssey from new information to implementation will improve. Okay, now to therapy. I like to mention to you that a lot of what I say is evidence-based, meaning it's me sitting on the podium telling you what I do. That's not really evidence. Evidence is using what you can find in the literature. It's recognizing the limitations of randomized clinical trials. And I think it's very helpful to differentiate between what's belief and what's been shown in quality studies. I have a bias, and this is evidence-based, for oral antiviral therapy. And my reasoning is that it limits ocular surface toxicity. You don't have to worry about if the eye is red, whether it's being caused by the oral agent. These drugs, oral antivirals, are extremely safe long-term. We have 3 of them in the US that are interchangeable for the most part. There is this admonition not to use valacyclovir in patients with AIDS. That is a controversial admonition, and I follow it for medical legal reasons only. HSV lytic infection or epithelial infection is a systemic disease. It has to reactivate, and it reactivates in the CNS, and systemic agents get into the CNS. I also have the bias for not the strongest corticosteroid available, but what I call the strongest reasonable corticosteroid. For me, that's prednisolone when you need an anti-inflammatory therapy. And I like to avoid pseudo failures. If you give a weak corticosteroid and the patient doesn't improve, you still have that potential arm on your treatment algorithm should I have given a stronger corticosteroid. Prednisolone gets into the eye well. You can always change to a weaker drug. I personally avoid difluprednate in HSV keratitis because we so commonly see intraocular pressure rises. And as you know, those IOP rises can be caused by HSV. And I hate to use drugs that generate confusion rather than clarity. HSV stromal keratitis with ulceration may be an exception to needing a strong corticosteroid. I have many patients that after starting them on an antiviral, and I'll show you that in a moment, I give something like fluorometholone once a day, and their epithelial defect and inflammation clears within several days. It's quite dramatic. So obviously, any recommendations I would make are based upon medications available in your region, but I've tried to do these based on concepts rather than the specific drug. For epithelial keratitis, it's an antiviral, period. As if it's dendritic, you can use a therapeutic dose. When it's geographic, I worry about long-term neurotrophic keratopathy, and I will usually go right to the maximum therapeutic dosing. In the US, that might be valacyclovir, 1,000 milligrams 3 times a day. I also really like, again, cyclovir gel, which we have in the US. We're about to get acyclovir ointment finally, but the ganciclovir gel seems to be extremely well tolerated by patients with very minimal toxicity. Stromal keratitis without ulceration, the treatment is a therapeutic corticosteroid dosing, for example, prednisolone 6 or 8 times a day, along with a prophylactic antiviral. And for me, that's, for example, valacyclovir 500 milligrams once a day, or acyclovir 400 milligrams twice a day. As I've gotten older, I've become minimalist in my therapy. I like to give patients medications they don't need to take as often, because I've learned that compliance improves as you reduce the frequency with which the patient needs to remember to take their medication. With ulceration, that gets flipped. So here I believe you need the therapeutic dosing of antiviral with what I call minimal touch dosing of corticosteroid. There's good evidence that in stromal keratitis with ulceration, there's very deep stromal viral replication. And through trial and error, I've arrived at this, which has, I think, been backed up by others' experience. In other words, a therapeutic antiviral that might be valacyclovir, a gram TID, and prednisolone once a day. I usually start the antiviral first, make sure they have it and they're taking it, and then I touch them with a little bit of corticosteroid. And it's remarkable how quickly these highly inflammatory lesions respond when you do this. They don't seem to respond to the antiviral alone fully. They might get a little better, but they don't heal. And then for endothelial keratitis, there are a couple of small clinical trials. In my own experience, both intentionally and by patient noncompliance, I've learned that you need therapeutic dosing of both the antiviral and the corticosteroid. And these patients can go from hand motion vision to 20/20 in 24 hours with a maximal dose of an oral antiviral and a 8 times a day dosing of prednisolone. At 2 weeks, I typically start tapering the corticosteroids. The antivirals can be reduced at 2 weeks to the prophylactic dose if you've started therapeutic dosing. What about prophylaxis? Well, the HEAD study, as I mentioned, never told us who to use it in. But these are eminence-based indications. I choose to offer prophylaxis patients who've had multiple recurrences of stromal keratitis. If they need to be on corticosteroids, I'd like to reduce that, so I give them prophylaxis. Patients with recurrent inflammation and scar and vessels that are approaching the visual axis, obviously our goal as corneal specialists is to preserve and restore vision due to corneal disease. And so I try to catch it before they need surgery. More than one episode of stromal keratitis with ulceration is an indication for me, because these are really the worst players and they almost universally lead to visual loss if not treated. And again, I'm very aggressive about using prophylaxis in patients who are having keratoplasty. And for me, very simply, I like the once a day dosing that I can do with valacyclovir. I increase the dose if they break through, and I also use more in atopic patients because I believe that more is required, but that's eminence-based. There's no hard evidence for that in a clinical trial. So I just wanted to finish up with 2 cases that I thought you might like. This is a patient I showed before. He was a young man sent to me by a corneal specialist. The corneal specialist told me he had treated the patient with oral acyclovir, but the patient said that he had never taken a medication by mouth ever. I believe the corneal specialist was just covering his failure. He had a corneal transplant for herpetic eye disease, was having trouble wearing a contact lens consistently because of recurrent episodes of stromal keratitis with ulceration, and he was 2400. We placed him on oral acyclovir as prophylaxis, stripped the pannus, and here he is, went back to 20/40 vision with his contact lens and was happy. So it was fairly simple. This is one of my favorite cases. This was a dentist who had been on disability for 10 years. He presented to me and said, I don't want surgery. I want to know, can you do anything for me that doesn't involve surgery? I have burnt out herpetic eye disease. And you can see something, there's a finding here, which we don't see very often, but it's a posterior collagenous layer, like we're taught to see in syphilitic keratitis, where you get these sort of cracks in decimase, very characteristic. This is not corneal, these are not decimase folds. And you see this opacity at the posterior cornea. And it's a layering of extra basement membrane by a metaplastic corneal endothelium. And you can see the cornea is swollen. He's 2400. And because you can never tell at first visit whether a patient has active disease, really, I placed the patient on acyclovir 400 milligrams twice a day and prednisolone 8 times a day. as a drop and asked him to return in 2 weeks. Here he is 2 weeks later with 20/40 uncorrected vision, and he went back to work as a dentist. Now he had his depth perception back. So that's really all I have, and I thank you so much for your attention, and I'm happy to answer any questions that you might have.
Thank you very much, Professor Chorosh. I think that was a very, very illuminating talk on the entire spectrum of HSV. And a lot of questions that we had in the chat were actually related to treatment as well. So most of the questions have been answered by the panelists. But I think I'm not sure if the panelists selected the option of answer to panelists and attendees.
We selected for everybody.
That's the,
No, but I think I have one question, and I think lots of other people have asked also the same. Dr. Chorosh, for how long maximally have you given valcyclovir or acyclovir for prophylaxis?
It's an important question, and so the short answer is, I have patients who've been on for their adult lifetimes. I acquired the practice of Debbie Pavin Langston, who many of you know, had a 50-year practice treating viral keratitis, and all of her patients had been on oral prophylaxis, many of them for over a decade, and I chose not to turn that apple cart over. It's very hard replacing Debbie Langston, because to her patients, she was a god, and you don't overrule God. I am interested in the work by Verhans from the Netherlands that suggested that in some patients with recurrent epithelial keratitis, they believed that they could show the emergence of a resistant virus. I had some concerns about the technical methodologies they used to come to those conclusions, and most of my patients on prophylaxis don't have recurrence, so I'll leave that as it is. But these drugs are extremely safe. I do ask and look at the renal function in all my older patients on long-term prophylaxis once a year. Most of them in the US are having a chemistry done once a year anyway, and it's available to me in their medical record. And so I pay attention to that. But outside of that, and the theoretical concern of resistance, it seems to be very, very well tolerated. So, I used to tell the residents it's one of the 5 safest medicines, and then a wise guy resident said, what are the other 4? Literally acyclovir could be given over the counter and it would meet safety profile for that. So the bottom line is, when the HEAD study completed, when they took patients off the acyclovir, they followed them for an additional 6 months, and their rate of stromal keratitis went back to what it was for patients who were on the placebo arm. So at least for that length of time, it didn't have an effect beyond when the drug was stopped.
One more request to all the participants, the attendees, is to post your questions to everyone so that everyone else can also see them. Many of the attendees have asked the question about acyclovir, and many of the panelists have been replying to them already. But a couple of questions that Dr. Chorosh, I still think that you should answer. And I heard in your talk, you said that in epithelial keratitis, you don't use any treatment, or it's not necessary. Is that correct?
No, I do treat epithelial keratitis because it does shorten the course. My point was, there's been a lot of research looking at drugs for the disorder, and it's a common, epithelial keratitis due to HSV is common, but it's rather disappointing when you realize in the studies that the treatment course has only reduced the length of the course of pain and discomfort and poor vision by several days, 20 to 30% at best. So in contrast, the blinding diseases have not been as extensively studied. Epithelial keratitis in a normal, healthy human being is not a blinding disorder. It typically resolves without sequelae. Although I have seen patients with many, many recurrences who over time start to develop some scarring and perhaps some astigmatism. So for me, epithelial keratitis is a relatively trivial problem that is easy to treat and has a defined outcome, which is recovery of vision, whereas the other forms of herpes keratitis, if not treated properly, will lead to visual loss and are not recoverable if not treated well.
So I couldn't get Dr. Quresh Maskati's question.
Dr. Maskati is asking whether you should do debridement manually.
Oh.
So the evidence, the trials in debridement are old and were not, randomized. Obviously, they were not terrific, and they showed a very marginal effect. I will share one anecdote from my friend Todd Margolis, who is very knowledgeable and experienced, who says that for epithelial keratitis, when he's sure of the diagnosis, he debrides and places an eye patch overnight. Herpes simplex virus doesn't grow well at body temperature. It grows better in the somewhat cooler ocular surface. So the surface temperature of the corneal epithelium is below body temperature. And it's known to herpes virologists in the laboratory that you like to grow them at 34 degrees rather than 37 degrees. So he has found, what he says, it works perfectly, and the next day the problem's resolved. I've never tried that, but that's what Todd has relayed to me. So I don't know that debridement, which again can create more discomfort because you've created a larger epithelial defect. If you have personal experience with it, it's not certainly contraindicated, and it's been published. The studies didn't really show a very significant effect.
So I have one question, Dr. Shadush. Acyclovir has been recently approved by the FDA. Not recently, but for us we had it all along. But you were not using acyclovir; you were using ganciclovir. You think there's any difference between the two as far as the outcome is concerned?
So, from what I understand from my friends and colleagues, acyclovir ointment has some surface toxicity. The ganciclovir gel, I'm only speaking from one-sided personal experience, has very minimal surface toxicity. I can't really tell you that one is better than the other. Unfortunately, ganciclovir gel has, because of our unregulated pharmacy and absence of competition in the large government programs, pharmaceutical companies charge whatever they want. Ganciclovir gel in the US has become extraordinarily expensive for those who it's not on the insurance company's list. And in some cases, several $100s for a small tube. So when I have acyclovir ointment available to me, I'll certainly be trying it. But oral antivirals, in most cases, are also very inexpensive. And although they're not FDA approved for epithelial keratitis, they appear to work, at least for herpetic eye disease. So, I don't have any particular preference for one over the other. I think in India, you have a vast experience with acyclovir ointment, and that's fine.
I wish we had much more time, and I wish the whole meeting was on HSV. It could well have been. We're running, as usual, time is our enemy. Just one last comment I wanted to say, because acyclovir all of us have been using it, and it's not really toxic for the surface. We've been using it for a long time. I think just in the interest of time, a lot of questions have come in, Dr. Chodosh, and especially they wanted to see your treatment slides again, but I know that they are published. So I think that we can send a link to all the participants.
If you'd like, I will PDF that one slide and email it to you, so Michelle, and you can
thank you.
Send
Excellent.
it as an email to everybody.
Like quite a few have asked for that.
Okay.
Treatment slide will be just great. Thank you so much.
Happy to do it.
So,
Thank you.
I think we just had an amazing talk, and this was really enthralling to listen about HSV. We'd like to move on to the next speaker. Paritosh, if you could introduce the next speaker for us.
No, it's Dr. Manisha. So
Sonu will introduce the next speaker for us. Dr. Sonu Goyal.
So 1 second, I think Dr. Quresh, I can't see, maybe he has joined as a audience. So can somebody, Sai or Kripal, call him or somebody to get him on as a panelist?
Sure, sir.
So let me introduce now Dr. Manisha Acharya. She is a senior consultant, cornea and refractive surgery services. She is the medical director of the Eye Bank at the Dr. Shroff's Charity Eye Hospital, Delhi. And she has to her credit a lot of awards the British Medical Journal South Asia Healthcare Award. She had a travel grant by the European Eye Bank Association, numerous best free paper poster awards, and she has also authored a book released by the Eye Bank Association of India on the eye bank recovery technique. So over to Dr. Manisha Acharya on HSV.
Thank you very much. I'll start my screen share. So am I audible and the slides visible?
Yes, ma'am. We can see the slides and hear you well.
Thank you. A very good morning and very good evening to respective participants and the esteemed faculty. At the outset, I want to thank the Scientific Committee AIOS for making this possible, and it's a great scientific fiesta, especially Dr. Somchala, for all the efforts you've put in. And it's very difficult to speak after Professor Chadosh, but I will try to present two cases which I have managed in my practice. So HSV, we all know that presents maybe like an epithelial dendrite to potentially blinding, necrotizing stromal keratitis. So we've seen all the presentations in the previous presentation. So this 13-year-old child presented with complaints of diminution of vision and pain and redness in left eye for the past 3 months. The symptoms had subsided with treatment with oral and topical acyclovir.
I'll do that. I've done. Okay. Can you see me now?
Following discontinuation. On examination, the right eye was essentially normal, but the left eye had...
I wasn't speaking. I said, why disturb people with my video?
Mute your mic, please.
Yeah.
No mind.
Admin, can you mute Dr. Muscati?
So the corneal involvement actually showed these multiple epithelial bullae in the center. You can see that disc which is forming with the stromal edema. But there was anterior stromal infiltrate which was measuring around 1 to 2 millimeters and keratic precipitates which were present on the endothelium. So we started this patient on acyclovir 5 times a day and prednisolone eye drop 4 times a day with homeotropine and a tear substitute for 4 times a day. A corneal scraping was done from that area which was having an infiltrate which was denser. The smear examination was essentially normal, but GIMSA staining showed multinucleated epithelial cells going more in favor of the viral etiology which we were suspecting from the beginning. The RT-PCR for HSV 1 and 2 was negative. The reports definitely came a couple of days later. 6 days later, with the treatment, the patient had a mild response. So we stepped up the steroids further to 6 times a day and continued the rest of the treatment. By 10 days, the patient was improving, and by 3 weeks, the patient had significantly improved with clearing up of the edema. The acyclovir tablet was then reduced to 2 times. Prednisolone eye drop was continued in tapering dosage now, and CMC again continued. 6 weeks follow-up, the patient doing much better and was then continued on prophylactic oral acyclovir 400 milligram twice daily and was asked to follow up 3 monthly. The patient did well with this prophylactic dose and was quiescent for 6 months. But despite being on this prophylactic acyclovir, the patient again presented with this epithelial dendrite. It was started on the topical antivirals and did recover. I'll take you to another patient, which was a 46-year-old male and had this very classical geographical ulcer. Was started on acyclovir eye ointment 5 times, a homeotropine and a CMC eye drop. 1 week post-op, the patient had started to definitely respond with blunting of the edges of the ulcer and was continued on the same treatment. But 2 weeks later, there was this deep infiltrate which has come up, which was not there previously. And with that, there was this dilemma which came up. Are we dealing with a stromal necrotizing or a stromal keratitis, a combined association, or a superadded infection? For this, we did scraping, which turned out to be negative for bacteria or fungus. And we stepped up our treatment, start adding oral acyclovir 5 times a day, and along with the topical, which is already on. and also added steroids in the form of prednisolone eye drop 4 times a day. And within a week, the patient started to respond. At that point, we reduced the steroids and tapering dosage and also the oral acyclovir to 2 times a day. The prednisolone was also put on tapering dosage and a very slow tapering dosage, and later on the patient was continued on low dose steroid, which is a load in a form of Lodex, which we get in. So I would like panel's view in knowing what is the prophylaxis protocol for recurrent cases, as the patient, even on the normal dosage, just a 13-year-old boy did recur on oral acyclovir. And also your call on long-term topical steroids or anti-inflammatory therapy in recalcitrant cases. So thank you very much for the opportunity.
So I think you wanted me and Dr. Sangwan to comment. I'll jump in. So the first case is interesting. That's certainly an unusual presentation. I think you did the right thing by culturing the patient. It almost looked like a Wesley ring on that first presentation. I was wondering about the diagnosis. I think in retrospect, you got it right. The patient improved dramatically on without the presence of antimicrobial therapy. The issue in a 13-year-old is clearly, the first issue is compliance. The second issue, which can be poor in 13-year-olds, the second issue is that I didn't have time to go into, is that herpes keratitis in children and adolescents is really a different beast than in adults. I think that's probably due to the levels of stress hormones that we have in children and adolescents. And it's been my experience that it's much harder to treat. In adults, it's generally a straightforward treatment course once you get to the diagnosis. But in children, it can be very tricky. And they can do exactly as you saw. They present with stromal disease. And then while you're treating them, they develop epithelial disease. And then when you reduce the steroids, their stromal disease worsens. And it's just a challenge. The second case, I was looking at and wondering, as you did, could this be something else? I think stromal keratitis with ulceration, unless you have a really strong history and you know exactly what it is, you should culture the patient. And in our practice, if we're very suspicious of herpetic disease, we may still go ahead and give antimicrobial therapy with an oral antiviral while holding the corticosteroids. You said it right. Was it a superinfection or was it stromal keratitis with ulceration? And I would say it's not clear to me at onset which it was. I would have held the corticosteroid until I had a negative culture and had given a course of topical antibiotics. But that reflects my general cautiousness, not necessarily right or wrong. So these are hard cases, particularly. Always think about compliance, and in young people, as well as atopes, and I probably should add a slide to my talk for HSV keratitis in children and adolescents, because I think they require higher doses of antiviral and very, very close follow-up. Verinder.
Well, I think, Jim, you covered most of the things. And Manisha, congratulations for managing these two very difficult cases. In adolescent or young kids, the HSV keratitis can be very, very atypical. I had a bilateral, almost like an endophthalmitis kind of a presentation many, many years ago. And when we cultured it, and on microbiology, it found to be HSV, then we treated with systemic steroid, systemic acyclovir, and recovered well. The question about prophylaxis and getting a breakthrough attacks is, as Jim said, only recurrence reduces, but it does not eliminate completely. So therefore, the recurrences or breakthrough attacks are likely to happen in some patients. Second, long-term use of low-dose topical steroids. Virus gets addicted to these steroids, and they need some dose of topical steroids to keep the inflammation down, keep the virus happy. And in many patients, I would continue very low-dose topical steroid on daily or alternate basis.
Thank you very much, Dr. Chadosh.
Just one point. Dr. Chadosh, would you increase the dosage of the prophylactic antivirals?
Yes.
So is that because you feel that it's not adequate? That's the reason why.
So if in the HEAD study, acyclovir was given at 400 milligrams twice a day, and that dose, I believe, was chosen because it's a standard prophylactic dose for vaginal recurrence. Those are very different diseases. And my personal experience is and practice is that when a patient breaks through prophylaxis, I consider increasing. So instead of, for example, if they're on BID dosing, I might go to TID, or I might go to 800 milligrams twice a day instead of 400 milligrams. And in children, I use higher doses relative to body weight than I might in adults because of this idea I have that it has something to do with stress hormones that are so powerful in children. You know, a young child can go from laughing hysterically to throwing a temper tantrum. Their emotions and stresses clearly are extreme. And I think that has something to do with the problem. It also could be that their immune systems are so robust and that some of the manifestations we're seeing are related to a better immune system than Dr. Sangwan and I have at our advanced age. So I don't know. These are all things in my mind, but they may be all false. But yes, I do use higher doses per weight in children. And yes, when I have a patient who breaks through with a visually significant problem, I increase either the frequency or the dose.
Thank you once again. Manisha, thanks for presenting such excellent cases. It's such an exhaustive collection that you have of these cases and all interesting spectra. I limited you to presenting only these two, but everything was very good. And
very nicely presented. Yeah.
Yes. Thank you, Professor, for joining us and taking out this time. I know it's very early for you, and we really appreciate that. And thanks, Dr. Salman, for your valuable comments, as always. I'm pretty sure that there are lots of unanswered questions, but time is an enemy, and it's chop. So we're going to move on to the next segment of this series. And I'll request Paritosh to just cue in the next speaker.
It's the Professor Elmer too.
Hello.
So Professor Elmer too is going to give us a talk on Acanthamoeba, which I actually keyed him in to tell us about what do we know, and I've called the bug a very bad bug. So let's see what he has to say about it.
Great. So we look forward to hearing from Professor Elmer.
Thank you very much, and thank you for the earlier introduction. One thing you left out was that I'm the other fellow from Bascom Palmer the year that Jim was a fellow there. So that's probably my greatest claim to fame. All right, let me go ahead and share my screen here. So today what I was asked to do is to go over Acanthamoeba keratitis. Now this is certainly something that's probably a little less seen among all of the other infections that are very common, including HSV, fungal, bacterial, etc., that you all see in common practice. But it is an important infection and something that often will lead to failure if it's not recognized. And recognition is really the major factor here. If you look at all of the things that are controllable in terms of coming to a good outcome with one of these infections, it's really early recognition. Any delay in recognition is the most common controllable factor that will lead to a poor outcome. Once you recognize the possibility of Acanthamoeba, you want to go for a specific diagnosis if that facility is available to you, and then start prompt aggressive treatment. And the reason for this is that Acanthamoeba keratitis is not an infection that will be cured in a day or two or even a week that you might see in bacterial keratitis. From clinical presentation, it's a very long and winding road for these patients. In order to get the medications they require, get an accurate diagnosis, and then the treatment course is non-linear. And I always mention this to people who manage these patients, is that these patients will do better for a period of time, then worse, then better, then worse. It's psychologically wearing, really, both for the physician and also the patient. So what are we dealing with? Acanthamoeba, as you know, is a free-living protozoa. It's found ubiquitously. It was first identified as an eye pathogen in 1973, but it's found everywhere, all around the world. And most of the outbreaks and infections can be traced to water. And we think of recreational water or pond water, but also household water is a problem. These are older studies, but you can see that as part of the burden of Acanthamoeba, it's relatively low percentage-wise in India. But in China, very clearly, you can see that there are places where the incidence varies quite a bit based on how many people are wearing contact lenses. And this is also pointed out in study in Brazil, which showed that as the country became more affluent and people started wearing more contact lenses, that the incidence of Acanthamoeba keratitis rose. So it's very important to understand what the risk factors are for Acanthamoeba keratitis, which occurs primarily in contact lens wearers in Western countries, but in any country can also be related to trauma and other exposures. Our experience really comes from over 300 cases that we've seen over the last decade and a half or so here at UIC. It's a continuing problem, as you can see here, just from our case counts year by year, that really hasn't decreased significantly. So what is it that would clue you in as to the possibility of this being Acanthamoeba keratitis? And you can see below, there are a number of different photographs. I think all of us would recognize that the central one would be highly suggestive of Acanthamoeba, but the patient on the left is also a patient with Acanthamoeba. So when you see patients, we know the risk factors are what will initially pique your interest as the possibility of Acanthamoeba keratitis. Contact lens wearers, as I've already mentioned, soft contact lens wearers and rigid lens wearers are really the ones at most risk, at about approximately the same risk. As orthokeratology becomes more popular, this has also been a risk that we've seen here in the US, and we have a paper that's currently in press and being in eye and contact lens, which shows that even in the US, orthokeratology is a risk. So that's something that's gaining increasing penetrance in India. It's something you should watch out for in these particular patients. And then, as Jim was talking about bilateral disease and atopes, there's actually a fairly high likelihood of a patient having bilateral disease, either presenting at the same sitting or sequentially over time. So the same risk factors that the patient has at home, but probably also their own immune systems probably have some exposure to risk that allows both eyes to be affected. There is no relationship, as far as I know, with atopy in these particular patients, but we have seen repeated infections in some. So Acanthamoeba keratitis initially is not something that is a infection that causes a great deal of necrosis. And so this patient that I showed you earlier, this patient could be easily mistaken for dry eye. You can see the epitheliopathy in the picture on the right. One of the keys here is, though, in these patients, that epitheliopathy usually stops before the limbus. There's usually a 1 to 2 millimeter area of clear cornea peripherally, which tells you that this is a central corneal problem, and this is a patient who would be at higher suspicion for Acanthamoeba keratitis. Along the vein of dendritic keratitis, nearly 2/3 of patients who present to us with Acanthamoeba keratitis were previously treated for HSV. You can see here, this is a patient with Acanthamoeba keratitis with what's known as pseudodendritic keratitis. These don't obviously have the form or the terminal bulbs you would expect to see in HSV, but you can clearly see the radial keratoneuritis. That probably developed later, and the initial clinician that saw this patient would have easily been fooled into thinking that this was HSV primarily. So if a patient, as Jim was talking about, they don't resolve in a reasonable way, you have to consider the possibility of Acanthamoeba keratitis in these patients that appear to be herpetic but may not be. As I mentioned in the previous slide, radial keratoneuritis is a hallmark, a pathognomonic sign that you would see in these patients. It's probably seen in only about 1/3 or less of patients, but if you see a radial keratoneuritis, you want to think about the possibility of Acanthamoeba keratitis very strongly. It has also been described in other infections, including Pseudomonas, but the vast majority of these patients are going to have Acanthamoeba. And as I mentioned earlier, once they get to a ring infiltrate stage, the diagnosis and the recognition of this particular disorder is much easier. This sort of classic Wesley ring with a central area of clearing, or even the deep stromal keratitis you see here on the right. Again, a mimic of HSV, but in these particular patients, that they have risk factors, unusual pain, and some are lacking some of the findings of HSV. You want to consider in these patients very strongly that they may have Acanthamoeba keratitis. So it can masquerade as a dry eye, other subacute infections, including fungal infections, microsporidia, herpes, and the vast majority are really treated for other diagnoses prior to coming to the attention of somebody who has a diagnostic capability of diagnosing this infection. So it's absolutely critical that the clinician understand the risk factors associated with it so that you can recognize and diagnose these patients early. In addition to the presentations I showed you earlier, something that may be more apropos in your practices is that this is often a polymicrobial infection, meaning that patients with Acanthamoeba often present with other infections, including Pseudomonas, fungal infections. It's been described with HSV, and also other amoebic infections. So if you have a patient who is not responding appropriately to therapy that you expect to work, you want to consider in your differential the possibility of a secondary Acanthamoeba keratitis that's also present at the same time. And this has really been described throughout the history of its known life of Acanthamoeba keratitis ever since the 1980s. And why this is important as far as recognition is concerned, that patients do better if you get them at an earlier anatomic stage. As Dr. Chodosh was mentioning earlier, if this is something that affects only the epithelium or the anterior stroma, the likelihood of a good outcome, meaning visual avoiding transplantation, is about 10 times greater than if you diagnose this at the stage of a ring infiltrate or a deeper keratitis. So it's extremely important in that sense to recognize the possibility early so that you can make the appropriate adjustments to your treatment plan. So in contact lens patients specifically, if they have any risk factors, just remember that Acanthamoeba keratitis needs to be on your differential diagnosis list. As far as diagnosis is concerned, generally you can, in the later stages, you can diagnose these patients with a ring infiltrate sort of by clinical history and examination. But in the earlier stages, you're really going to be reliant on other studies, and that includes microbiologic methods. Non-nutrient agar with Enterobacter is probably the most commonly available media, but even then, laboratories struggle somewhat to identify this microbiologically. You have excellent laboratories there in India, and I know that even with a simple KOH prep, the sensitivity and specificity can be quite high in the 80 to 90% range. So I would definitely seek out a microbiologist who is familiar with the diagnosis of Acanthamoeba, and I think there is a great deal of expertise in India, probably better than here, that can help you with that. Imaging, if you have it available, confocal microscopy, I think is now proven to be a very useful adjunct, but it's very important really to try all avenues of diagnosis, because very often you'll only find one of these to be positive, but that will make the difference in your patients in terms of their prognosis. As far as molecular diagnosis, this is becoming better and better with each passing month. As PCR is validated for this, it has about equal sensitivity, interestingly, to in vitro confocal microscopy in most of the current studies, but hopefully as the tests improve, that will improve as well. So as far as routine medical therapy, this is where a challenge comes in, and that is that much of the routine medical therapy that's used for Acanthamoeba keratitis is not something that's easily commercially available. Debridement, which was talked about with HSV, is probably helpful to a certain extent, especially in epithelial disease. We usually use a combination of medications, including some sort of diamidine like propamidine or hexamidine, along with a biguanide, and that's either chlorhexidine or PHMB. Unfortunately, the chlorhexidine and PHMB are compounded currently. My understanding from Dr. Dart is that they are going to have commercially available PHMB in Europe within the next year or two, now that it's finished its studies. We'll talk about some systemic medications and the role of steroids as well. So this is what you hope for, is a patient with a very early disease. This is a 16-year-old soft contact lens wearer with pretty much only epithelial disease. And you can see very clearly the irregular pattern of the reflected light off of the iris here. She was positive. We started on chlorhexidine, did a mechanical debridement at the time of her visit. Within 10 days, her vision returned to 2015. We treated her only for a month in this particular case, and she had no recurrences afterwards. So this is an ideal situation where you identify a patient early, are able to mechanically debride them and treat them for a relatively short time with good success. And really, if you look at the results from Acanthamoeba keratitis in the past, the visual results have actually been pretty good if you compare them to bacterial and fungal keratitis, mainly because there isn't a lot of initial necrosis in these patients. So if you are able to treat them medically, generally they do reasonably well visually. We have found recently, and it's been published out of the Wills Eye Institute, that more recent cases are becoming more resistant to therapy. They're requiring more time in order to resolve their infections. They're getting poorer outcomes, and they're needing more drugs. This is our personal observation as well. And in talking to Dr. John Dart from Moorfields a couple of years ago, they were also seeing the same problem. So it's unclear whether this is an issue with the medications or the organism itself is changing in some way, but more recent evidence suggests that visual prognosis is less favorable than it had previously been. As far as treatment failures are concerned, very briefly, the things that I'll talk about are extracorneal disease, the possibility of drug resistance, and then also very briefly at the end, surgical management. Like all infections, prior corticosteroid treatment of any kind results in a poorer outcome. So the lesson here is basically if you have a patient who has an unknown keratitis, which is not responding properly to either bacterial or antifungal therapy, that the addition of steroids, if they have acanthamoeba, is going to worsen their prognosis. So if you have a thought that that may be there, you want to definitely pursue specific diagnostic tests to make sure it's not there, but prior corticosteroid therapy is unhelpful in these patients. These patients, interestingly, also have a wide quadrant of extracorneal disease, mainly non-infectious things like dacryoadenitis. They can get a non-infectious scleritis. They can also get an infectious scleritis, as well as other adnexal disease. So these patients not only have corneal disease, but they may get a choroiditis, and these are often inflammatory and not infectious. So as far as immunosuppression is concerned, John Dart's article back in 2009 really highlighted the importance of using immunosuppression in those patients who are appropriately treated with anti-acanthamoebal drugs. So while prior treatment is bad with steroids, after beginning treatment, it is often necessary in many patients who have either extracorneal or adnexal disease to consider immunosuppression. If you don't immunosuppress these patients, unfortunately, they can get a severe scleritis and end up with a tisical eye from ciliary body shutdown. So it's important to walk that fine line once they're on therapy. And then briefly, as far as strategies, these are some of the strategies if your standard medications don't work. This includes the use of benzalkonium chloride containing compounds early on in the process, which can help with epithelial forms of disease. A recent study out of Moorfields showed actually that propamidine, most of the anti-acanthamoebal effect comes from the benzalkonium chloride rather than the underlying propamidine. So benzalkonium chloride can be a partner, especially in those patients where you don't have access to treatment immediately. So the use of a non-BAK compound or antibiotic would not be preferred in these patients where you suspect acanthamoeba is a possibility. Pentamidine is another diamidine that's in that class, which has been used in the past. It's extremely toxic, and evidence for its utility in these patients is somewhat limited. Most of the azoles don't show significant activity against acanthamoeba, and the exception of that is going to be voriconazole. Either oral or topical has been described as an adjunctive or even a primary therapy in a couple of patients that we had for deep-seated acanthamoeba keratitis. But I find that this is not consistently effective in most patients, but can be helpful, especially if it's the only thing you have available. The newest class that's interesting is alkyl phosphorylcholines, primarily miltefosine. You can see here, I'm not going to go through all of the complications, but it's a common drug used for leishmaniasis around the world. Actually, it's probably the drug of choice now. This was the first patient we treated in 2011 on an experimental IND basis. You see this patient had multiple recurrences after 2 grafts. We started the miltefosine, and the patient was able then to clear her infection and actually maintain 20/60 vision for quite some time with a clear graft on the bottom right. I know Bhupesh has really pioneered this from a topical treatment. It does have some effect, obviously causing some inflammation in the eye. We've looked at this in our own patients. We've had 13 patients, all of which have done well. We have had a couple of failures as well, but generally this is much more effective. It's probably the most effective oral medication we've had access to. Not 100% effective, but certainly more effective than voriconazole. And then the last thing I want to talk about is surgical management. If you have acanthamoeba that's central and you know the borders, I think a traditional PKP or a DALC in these patients actually does quite well. As you start to get larger, these patients, unfortunately, you start to get into their drainage angles and into their iris. Large penetrating keratoplastics can work if you can avoid those areas. You can see in the photograph here on the right, this patient did very well just with a large 9.5 millimeter PKP. But if you're suspecting, as in many patients with acanthamoeba, that there may be extension either to the limbus or into the sclera or into the very peripheral cornea, that can be a significant problem. And in this particular case, recurrence in a transplant usually will take this appearance, this sort of crescenteric advancing area of granularity. That's usually a fairly advanced sign of reinfection of a transplant. In those cases, when you have to go larger, doing a standard trephination into the peripheral sclera can cause significant derangement to the drainage structures in the eye. So our preference has been really to go horizontal. And you can see here in the schematic, this is essentially an extracapsular cataract wound entering just anterior to the trabecular meshwork and removing both sclera and cornea in these patients, but leaving behind many of the vital structures. So this is a scleral keratoplasty of a different type, where we basically replace a horizontal incision rather than a vertical one. And I don't know, in the interest of time, we can go through this quickly, but basically this is a dissection all the way around 360, as you can see here. We're going about 80 to 90% depth, and this is taken 360 degrees. And then here, using a crescent blade, an initial entry is made up into the gray line. And then that's taken also 360 degrees around the cornea, so that you're basically left with an extracapsular cataract wound that goes all the way around, or a scleral tunnel that goes all the way around the cornea. And that's removed in a horizontal fashion. This is actually a case I just did 3 weeks ago. This is all we do during the quarantine. So yes, we are doing transplant. And you can see here as we remove the last bits of it, and then the corneal scleral button then is attached. And you can trim this to size as you go along, but the final appearance is like this. And you can see here, this is the patient that I was just showing. This is 1 week after the transplant. Anterior segment is deep, and the iris is relatively normal in this patient with normal pressure. This patient actually ran into the problem of elevated pressure. You can tell the iris is dilated from chronic acanthamoeba treatment and an infection. This patient actually has a tube shunt, a modified scleral dissection that I did here. There's a tube shunt in the anterior chamber, and this is actually the day after surgery. She's actually doing quite well as well. This is a previous patient. These patients, nicely, because it is a scleral keratoplasty, is that they have very little astigmatism. And this patient is about 5 or 6 years out from her surgery. Had one small rejection of her endothelium at one point, but maintains 20/25 vision in this eye, uncorrected after cataract surgery. So thank you very much for allowing me to participate in today's symposium. It's really an honor and a pleasure to see all of you. And I hope for the best through the pandemic as it burns itself out and any other natural disasters that may occur. Thank you very much.
Thank you, Prof. That was awesome.
There are several questions coming in. Thank you, Elmer. That was absolutely spellbinding to listen to. One question was about, well, many people have also shared their experience about Acanthamoeba keratitis, in which the patients had large epithelial defect and stromal haze. This is from Tanuj. and they have diffuse endothelial dusting. So the moot point is that because of the large epithelial defect, these were difficult to heal even with AMG, and then the drugs that we use are so toxic. So I think this is a very important question. So how do you manage this? In fact, even I have a patient right now with a PED, an anti-Acanthamoeba treatment, and secondary glaucoma. So the epithelium just doesn't heal.
Yeah, the biggest challenge in those cases is to determine whether that patient is still infected. And that's always difficult. I mean, you have a large epithelial defect. These patients are neurotrophic, significantly so. People have used AMT, but using a tarsorrhaphy, and if you still think they're infected, getting medications to the cornea is a challenge. This is where I think relying on oral medications and systemic medications and reducing surface toxicity can be helpful. Cutting back as much as you can on anti-glaucoma medications and also any topical therapy. If you can substitute oral therapy for it, I think that can be very helpful. I've had many patients, though, the epithelial defect in these patients is not necessarily a sign that there's still infection. And that's where a repeat confocal microscopy may be helpful, or scraping. If you can show that the patient doesn't have persistent infection, you'll have more confidence in reducing the surface toxicity from the medications. And then finally, we had a patient who's had a persistent epithelial defect for some time. We actually stopped all medications months ago. And really the neurotrophic aspect, we started topical neurotrophic growth factor in that patient, and they healed actually quite quickly. So that can be a major factor in the epithelial defect and not actually infection or inflammation.
So, Shila, one comment from Dr. Mahipal Sachdev, because he had gone, I remember, if Nikhil can remember that, gone to US and did his fellowship with Dr. Dwight Kavanagh and did study the ConfoScan for the first time and then gave a lecture in RP Center, I remember, as a postgraduate student.
Yeah, but unfortunately didn't have Acanthamoeba at that time. But I remember when we came back, those were the first cases of Acanthamoeba when we were running the cornea clinic that we described in RP Center. And I still remember having carried a big bottle of PHMB from US, the swimming pool disinfected, and tried to use that. I think Nikhil was there also, and maybe Dr. Tityal might remember it. So that's about it. I think it's a difficult bug to treat, and nice to be refreshed with all the latest what is there in Acanthamoeba. I think Professor Elmer has really given a great overview, and I think the cases, as has been rightly pointed out, are with contact lens wearers, swimming pool, etc., bad water. And in India, we do keep seeing these cases. So thank you very much. I think it's a great, and now I think you people have worked and others have also been able to see on the confocal microscope the Acanthamoeba per se. So that was a prototype that was being developed in 89-90, the confocal that we were working on in Georgetown. So that's about it. I think things have moved a lot.
Thank you very much, Dr. Mahipal. I think that you're first and foremost a cornea person, and then the other things come into place. We can claim you. So there's just just a couple of questions around the same point, and then I think that we'll close the questions for now. These questions around the same point, that since it's in the US, at least it's after contact lens usage, and it's probably this Dr. Jagdish has asked a very important point, that do they first come to the ophthalmologist or to the optometrist? And the second point is that once it does heal, do you put them back on contact lenses? What do you do?
That's a very good question, actually. I think if you look statistically, Acanthamoeba patients usually go through an average of 3 or 4 eye care professionals before coming to a diagnosis. So the answer is yes, they actually do present to primary care ophthalmologists and optometrists. So it's not something that is unheard of. As far as getting back into contact lenses, it's really shocking that these patients are always asking that on their first visit, when they can get back into their lenses often when they don't have a lot of pain. And the answer to that is curious. I mean, as I mentioned, there may be some predilection or susceptibility of certain patients to Acanthamoeba keratitis. And the incidence of patients having recurrent or new episodes is really higher than you would expect based on the population average. So I always make them aware of that, but the most important thing is they need to do something differently. And going into daily disposable lenses, for example. They may not have a decreased incidence of bacterial infection, but the chances of contamination are much less. And they really have to change their practices if they want to go back into contact lenses.
Thank you. I think we'll go to the case, which is also a case on Acanthamoeba. And if Parikshit could just bring that in for me. Maybe Parikshit is...
sorry. The next case is by Dr.
Unmute, Parikshit. Unmute.
Dr. Nikhil Gokhale needs no introduction. Dr. Nikhil is a leading cornea surgeon from Mumbai and a star of our Maharashtra Ophthalmology Society award in cornea in this part of the country.
Feroz, we cannot hear you in case you've not unmuted yourself.
Hello, can you hear me?
Yes, we can now, Feroz.
Yeah, hi. It's my pleasure and honor to introduce our next speaker, the president of Cornea Society of India and the past president of Bombay Ophthalmologist Society, the young and excellent academician, Dr. Nikhil S. Gokhale from Gokhale Eye Hospital. Apart from being a cornea specialist and an academician, I realized that he is a taxonomist as well. So I hope it's more to do with plant taxonomy or probably a cornea taxonomist as well. Over to you, Dr. Nikhil, and please answer this question of mine. Thank you.
I'll just share my screen. Can you see my slide?
Yes.
Yes.
So I thank the AIOS Scientific Committee and Dr. Somashila for me to be here today with all of you. She wanted me to present a case that I've managed during the pandemic. And I in fact have been managing 2 patients of Acanthamoeba ulcers. And I'll be showing you this particular case, which was a really difficult situation for me. And he's still undergoing treatment, although it's not fully complete. So this was how the patient came to me. He was a 44-year-old gentleman with diabetes. And he just said categorically that he had only 5 days history of redness, irritation, and he was using commercial steroid antibiotic drops. And subsequently, he developed this ulcer and he was referred immediately by the local ophthalmologist to me. So basically he had a ring infiltrate which was all around with a large epithelial defect and which was sparing the central cornea, of course. Looking at this picture with a short history anyway, as a routine, I sent all the smears and cultures and I started the patient on levofloxacin and atropine. However, at 48 hours, the reports were negative. There was nothing in the slides or the growth, and the patient was worsening on day 3 and day 5 following this. So I put the patient on vancomycin and fortified topramycin. By 1 week, there was absolutely no response to antibiotics. The epithelial defect was total. At this point of time, I thought it would be wiser to take a second opinion and do a repeat microbiology at a different setup. So I sent him to one of my colleagues who again repeated the same protocols for microbiology. However, again, the results were negative. At this point of time, the patient decided it was enough and he was not willing to travel or take any further opinion or testing. Then returned back to me on about day 18. At this point of time, he was significantly worse with now 360-degree limbal involvement. So I had to talk to him and motivate him for one last workup, which was only going to be smears. And I had to talk to the microbiologist to see and tell him that probably we are losing his eye, and we need to really look at the slides and check what's happening. And at that point of time, he told me that there is Acanthamoeba in the calcophore staining. The same day, I started the patient on chlorhexidine and PHMB, and continued his tobramycin and atropine, and continued to follow up. And within a week of the anti-Acanthamoeba therapy, he actually looked still worse. There was significant inflammation inside the anterior chamber with some fibrin-like reaction. There was annular guttering and limbal involvement with extension looking as if onto the sclera. At this point of time, I added oral doxycycline and was considering whether we can apply a glue onto the thin area. 9 days later, the picture looks still worse. He is continuing to go downhill. There was scleral inflammation as well. The patient's pain was manageable with oral diclofenac. Somehow I could not manage to do a glue bandage lens because I was alone in the clinic at that point of time, and the lockdown was just going on at that time. Another 2 weeks passed, and the thinning at the limbus was only getting worse with active scleral inflammation despite the anti-Acanthamoeba therapy. So I sent an SOS call to my Mumbai cornea colleagues, and I was lucky that one of my colleagues in a multi-speciality hospital could do a little bit of debridement and glue at the limbus so as to support the thin area. About 3 weeks later, most of the glue was not there in place, and actually there was a pannus and a vascularization all around. The glue had more or less sloughed off, but the bandage lens was still there. The eye was looking quieter. The scleritis had come down to some extent, and I reduced the frequency of medication. 3 weeks down further, this is day 94 of treatment and day 77 on Acanthamoeba treatment. When I saw him last a few days back, there was conjunctivalization all around. There was a centrally overhanging corneal tissue. I think the vessels are invading below it, and this is how the corneal overhanging lip is there. He has no pain now. The scleral inflammation is settled, but there is scleral thinning all around, as you can see. And I expect that over a period of next few weeks, he will have a totally conjunctivalized surface with probably underlying scarring and thinning. Some of the thoughts that came to my mind as I made this presentation was that one of the factors that the patient's very short history of 5 days made me think that this was a fulminant infection, and when smears are negative for fungus, I believed it was more probably bacterial in origin, so I was trying to give antibiotics. However, when the microbiology was negative at 2 centers, I felt I was probably wrong, and maybe that this could have been an Acanthamoeba. Down here, I must confess that sometimes we still need to talk to our microbiologist, and we need to keep discussing with them. Otherwise, sometimes the technicians report, and sometimes the reports are not, negative. And even after so many years in practice, I think I'm still learning from every new patient that I see. And some of the questions that came to my mind were that in a cornea practice, at least, is there any role of starting empirically anti-Acanthamoeba therapy? I feel it may not be a safe option for general ophthalmologists without a proper diagnosis. I myself, of course, do start this treatment when I see radial neuritis or a very typical pattern, but short history, I think, was something that made me go wrong. I don't know whether it is reported to get it so quickly, such advanced disease. Would anyone have done a keratoplasty if corneas were available at any point of time during his treatment? Any systemic medication, as Elmer mentioned, maybe voriconazole or any other drug would have helped, have been used. Would anyone use oral steroids in such a case for the scleritis? Considering that we were able to manage his pain, it wasn't very unbearable. And maybe once the surface heals after a year or 2 years, would someone maybe tell us if surface reconstruction or a keratoplasty is possible in such a severe, sort of pathology? And I must thank Dr. Devang, Dr. Suresh, and Dr. Jyoti Prakash, the microbiologist, for helping me in treating this case. And I think the coronavirus seemed to be harder than the Acanthamoeba in the current pandemic. And I just wait for the good times to come back again. Thank you.
Thank you, Nikhil.
Thank you, Nikhil. Go ahead.
Oh, he asked all the perfect questions. All 5, I think, are the most difficult. I think there is a role for empiric therapy. I mean, if you don't have microbiologic backup for it, even in those patients that are negative, I think that using them, they're relatively safe, honestly. The topicals, and they're broad spectrum, and they do have activity against fungi and bacteria as well. In this particular case, I think one of the reasons it may be fulminant, as I mentioned, patients who have either a large load of Acanthamoeba or if they have a co-infection. So this patient may have had a bacterial infection that was acting as prey. That it's been shown experimentally that Acanthamoeba that either have endosymbionts or in areas where there's bacteria or other food sources, they become much more pathogenic, much more inflammatory. So I think that's probably at least a portion of what you experienced here in this particular patient. 5 days, without question, is very short. But I think that those are probably 2 factors you'd want to look at. I think oral medications in a patient who has deep disease like this, I would try to start them initially, if at all possible. I'm trying to remember your other 2 questions. What were the other 2, the last 2?
The other question was about keratoplasty, whether at any point one would consider, and oral steroids, because scleritis is something that some people advise to use oral steroids. So in such a situation,
I think once you had the patient under therapy, appropriate therapy, that steroids would have been a consideration. And the reason for that is the scleral thinning that you see there. It's going to be very difficult to do a transplant with no foundation. And then also that inflammation has probably destroyed the ciliary body so that they're relatively hypotenuse now. And so the eye may be pretisical by the time you get into the possibility of surgery. So I think steroids are a necessary evil at some stage, but you have to make a decision whether the eye is going to survive the infection or not. And it's going to be one or the other in that particular case.
Thank you.
Sure.
Dr. Muscati?
Yeah, I was just saying that one take-home message which I want to give everyone listening is that unlike what Elmer too stated in the US, in India, we see more than 50% of our Acanthamoeba without any contact lens. In fact, there's a paper from South India where they found it more in farmers who are working barefoot in very muddy waters, and that muddy water splashing caused the Acanthamoeba. Nikhil again showed a comorbidity. We've learned to be very familiar with the word comorbidity because of COVID, but comorbidity in this case was diabetes. So again, the diabetes may be fluctuant, not well controlled. So these are the patients that we see, and I too have from all the Acanthamoeba that I've seen more without contact lens history than with a contact lens history. The treatment part has all been well elucidated. You talked about keratoplasty in the later stage. Elmer talked about the K-plasty, which would be very difficult with the guttering that you had to do in the initial stage. But in the later stage, after everything is all healed and it's not, suppose it doesn't go into pre-thicical and it remains normal, you could do keratoplasty, of course, with a peridectomy and all sorts of things, knowing that the limbal stem cells are fired, knowing that the sclera may be involved, that there might be cyclitis post-op. So with very guarded prognosis, yes, you could attempt if the PL is good. At some point, if after one keratoplasty, I would then go in for a Boston keratoprosthesis. So I am low level of inducement. I jump easily into Boston PK, but here I would still do first a PK and then go as a second stage into a Boston keratoprosthesis, provided everything else was okay. Thanks.
There are a lot of questions on what else can we use, because PHMB is certainly not available in pharmacies, and though chlorhexidine is, but
yeah.
The question
I have been using, my daughter is a dentist. I have been using triclosan, which is supposed to be, according to my daughter, a little better than for dentists. They prefer triclosan to chlorhexidine. Chlorhexidine is also a mouthwash. So I've been using triclosan very empirically, diluting the dental mouthwash as 1 in 10 and using this sometimes in desperate situations. In Mumbai, we do get the propamidine available. Golden Eye and Broline are some of the trade names that we get this from time to time. But otherwise, I've jumped from chlorhexidine to triclosan.
Elmer, you have actually studied the role of BAK rather than the actual molecule. Could you just say that once again for the benefit of the audience?
BAK actually, for certain strains of Acanthamoeba, is as effective as hydrogen peroxide, which is actually fairly helpful. The only problem with benzalkonium chloride is it doesn't penetrate well into the corneal stroma, but in the early stages, it can probably reduce epithelial spread and treat the superficial disease much more effectively. But experimentally, it kills both tryphozoites and cysts. And so if you have nothing else available, you can at least start with that before they get to someone who can get you the compounded medications.
I have a question for Elmer.
Yes,
yes.
sir.
Can I ask one question? Would cross-linking help in these patients?
I left that out of my talk. It's one of those things where it probably has some benefit in the very early stages. But once it gets to a deeper stage, cross-linking will not reach the deeper areas of the cornea where it resides. And it actually will cause a significant uptick in inflammation, sometimes catastrophically so. So I think in early disease as an adjunctive therapy, it can be a good stabilizer. But most of the evidence suggests that if it's a deeper disease, especially that's by the time it's diagnosed, that the cross-linking has limited utility there.
Because I consider, if you do in early stages, it may have a value because these Acanthamoeba, trophozoites will be, eating the keratocytes. Mm-hmm. So if you do a early stage intervention, maybe cross-linking, even I can, think of doing a DAL type of procedure, which can take, the infection load from the eye. And looking into a medical treatment is not great in these cases. So early surgical intervention may be the choice in some cases.
Yeah, I think there are quite a few of us in the panelists who would agree on DAL, Dr. Namrata, Rishi, Bhupesh, quite a few of us actually, early DAL. Rather than prolonging.
DAL can also, you would prevent a scleritis going into the beyond the limbus into the sclera, when you can actually do little about it except for giving steroids and immunosuppressing it.
So we'll move on to the last segment.
I think in terms of initial investigation, we all do a confocal microscopy in these cases, and that gives you a real clue for doing the management for such patients.
That's a very good point. Thank you, sir. Thank you very much, Professor Elmer too, and thanks to Dr. Quresh Maskadi for discussing this wonderful case, so well presented by Nikhil and so well managed, I must say, Nikhil, whatever the outcome is, unfortunately.
In the pandemic.
The pandemic, exactly, yeah. We'll move on to the last session, and again, Parikshit, I request you to cue in the next speakers.
Is Dr. Bhupesh, a cornea consultant from LV Prasad. So we have somebody to introduce him.
So we have our next speaker, Dr. Bhupesh Bagga. He is a consultant in cornea cataract services and children's eye care Hospital in L. Prasad Eye Institute at Hyderabad. He did his fellowship from the same institute. In addition to his clinical work, he is a researcher, and his research work is focused on corneal ulcer treatment. He is also involved in managing pediatric corneal disorders and complex ocular surface diseases. He is an investigator of grants related to HSV keratitis and Pythium keratitis funded by ICMR and DST. He has been actively involved in teaching residents and fellows. So over to you, Dr. Bhupesh Bagga.
Hello, good evening, everyone. And
good evening.
Hope I was audible.
Yes, sir. We can hear you.
my slides are... No.
Just waiting, Bhupesh.
Nikhil has to know stop share screen first.
That.
Yes, Bhupesh, you're in.
Okay. So thanks again to AIOS Scientific Committee and especially Dr. Somashila for the kind invitation and giving me opportunity to present my case. So I'm going to present a case of Pythium keratitis. Who is actually 41-year-old female presented in 2016 from Prayagraj, Uttar Pradesh with a redness, painful decrease in vision, along with white discoloration of the left eye since past 1 month, with a vague history of giving something fall during cooking 1 month back. So she was actually diagnosed and managed as microbial keratitis as a Citrobacter grown in the culture, which she was carrying the medical report and which was sensitive to moxifloxacin, erythromycin and all, and resistant to ciprofloxacin and ofloxacin. So based upon that and other clinical features, the treating cornea specialist started on voriconazole 1 hourly and moxifloxacin 1 hourly, along with atropine and tablet astazolamide. So this was the, I'm going directly to the cornea picture. This was the clinical picture of the cornea, which you can see with a dense infiltrate over this area. This area is almost thinning around 70%, which unfortunately slit is not on that. But the important thing is there is a guttering around the infiltrate all around. This area is relatively clearer with fine tentacular-like lesions with extensions, with circumciliary congestion, and these are the points which I was trying to tell. So based upon that, we made diagnosis of microbial keratitis and differential based upon the history of 1 month with the Citrobacter grown in culture from elsewhere, but worsening on antibiotics, worsening on antifungals, the history of trauma while cooking something. So clinical pictures which I just mentioned, like fine tentacles, are favoring either fungal or Pythium, but she was worsening on antifungals. Peripheral guttering along with going for Pythium as well as fungus both, but more towards Pythium keratitis. Pinhead lesions are more for Pythium as well as fungus both. So our differentials are in between the fungus or Pythium, or it can be mixed infection as Citrobacter, which is like a gram-negative bacteria grown from somewhere else. So if you just think about the Pythium keratitis, this is a plaque-like lesion. The typical lesion presents like a plaque-like lesion, whitish lesion with granular and surrounding granularity. If you carefully look, you will see some fine tentacles and pinhead lesions around that plaque. Similarly, in other patient, like presenting like in hypopyon, but common things is the raised plaque and a guttering, along with fine tentacles and very fine tentacle and pinhead lesions. Clinically, both are looking similar, but few differences are there, which are like in Pythium, you see fine tentacular lesions, which are very thick and very fluffy in cases of fungus, but in early cases of fungus still can mimic Pythium keratitis. You won't see guttering like this in early stages of fungal keratitis, but you do see sort of guttering around the infiltrate and raised plaque in Pythium keratitis. So we scraped and we got filaments. I would just say filaments, but if you see the filaments are, if I am marking here, this filament is like this with only one clean septa I can see. Rest all are aseptate or sparsely septate, which is more clearer in KOH, which is like aseptate band without seeing any septate. And the classical fold, like which you see here, which is very evident in KOH, which is not very clear in the grams. So based upon that, we are actually seeing a broad branching aseptate, sparsely ribbon-like filament. On microbiologically, we can differentiate these two organisms, but yes, there are certain patients where actually not able to differentiate very clearly, but in majority wise, we can see more septae and thinner filaments in terms of fungus, but sparsely septate or aseptate in terms of Pythium. Both organisms are different in structure of cell membrane also, and the important thing is that fungus has ergosterol, but Pythium doesn't have. So that actually gives that why this patient, if on Pythium, is not responding to voriconazole. Second thing is the growth on the chocolate agar is very, very faint, as in contrast to fungus, which is actually very clear. In Pythium, you see very submerged thin growth with radiating edges, which when we transfer from chocolate agar to aqueous media with some garnition leaves, we can actually generate spores from the sporangia. So this actually confirms the diagnosis of that we are dealing with the Pythium. So if to make a diagnosis, we are having clinical signs of tentacles, pinhead lesions, guttering and plaque, with worsening on antifungals, with smears showing aseptate, sparsely septate, ribbon-shaped filaments with culture and zoospore formation, actually towards Pythium keratitis. So now we have made a diagnosis of Pythium keratitis. So Pythium is basically a oomycete, which was actually initially diagnosed as a fungus, but later on, when we actually come to know that actually forming spores, and this is the technique of form spores, which actually come out to be a oomycete. So it was initially diagnosed as hyphomycosis destruens, which literally means that is the fungus which destroys literally everything. It is a human pitheosis, basically a disease to start with tropical and subtropical countries as well as temperate, but we do see cases from other all over world. Now we have case reports from all over the world of human pitheosis. Human pitheosis actually can be described in 4 categories, but most common is vascular, and second most common is ocular. The most important risk factor in terms of non-ocular is the thalassemia hemoglobinopathy, while in ocular pitheosis is related to water. Rainy season is increased incidence, farming exposure, direct contact with water resource, and there are plenty of case reports with the use of contact lens use along with the Pythium. So it's not only Acanthamoeba, which is very commonly associated with this. Pythium is also coming with second very important organism. Coming to management point of view, initially it was diagnosed as unidentified fungus, so it always been treated as with antifungals and then worsened. So this study actually, if you see the 30 out of 14 patients got enucleation or evisceration, but they came out to the conclusion that if you do early surgery, actually you can salvage the globe, but not visually outcome. This study from India actually says that from 46, 42 actually went surgery, but out of that 42 patients, 26 got very bad recurrence. So they also advise that early surgical intervention is the most important. So for this patient and for Pythium per se, the uncertainty exists, that uncertain response with medical treatment, outcome of surgical treatment is also very poor and high chance of recurrence of infection, poor graft survival. So what to offer to our patient? Like if you see that our patient was having late presentation, advanced keratitis, as well as central stromal thinning. So most of us think about that we should go for early keratoplasty, or now the early late is there, so we should go for keratoplasty. But some of us thinking that why should not try medical treatment? So based upon the drug susceptibility testing which we performed in our lab, we come out to a protocol to treat Pythium insidiosus keratitis medically, and we managed to see some 14-15 patients, and we published in 2018 this paper in Vigio. Based upon this initial experience, so we thought of trial of medical management with patient counseled about that and observe for thinning with explained prognosis that patient definitely may or may not require therapeutic ketoplasty. Because of high recurrence rate, we try medical treatment. So we tried with combination of linezolid along with erythromycin ointment along with oral erythromycin tablet. So this was the patient at presentation. After 3 days, if you see that little thinning is more clear with little bit of consolidation of the endoexudate, which now appearing now. With a haze of 14 days, the difference is little bit obvious that this cornea, which was little bit of fuzzy, actually started clearing up. And to our excitation, this central cornea also was getting clearer, but the thinning progressed. So we applied tissue adhesive with very close follow-up that still that patient may need therapeutic ketoplasty early. But on follow-up, they started consolidating with vessels, as Dr. Nikhil's patient of Acanthamoeba patient is started same consolidating as a plaque, which I am just thinking that why both are behaving as exactly like a similar way. And then is after 105 days, it became like a central plaque, which I removed surgically and applied tissue adhesive, which after 150 days, it's completely healed. So we make a strategy that we should try antibiotic even in the large Pythium keratitis rather than going for treatment, surgical treatment. And if it worsen, then go for treatment. So we recently, this paper recently got accepted in ophthalmology, where we described that it can present as like in 4 format, whether like this 4A, 4B, 4C is the like our patient, 3A, 3BC is like without formation of plaque and just resolve like other microbial keratitis. But 2A, 2BC and 1 is actually a different way, that 1 actually worsened on medical therapy and with large therapeutic graft was required in this patient. But 2nd improved, but central perforated during the healing process and we need sort of optical ketoplasty. So this way it responded. So yeah, I'm done. So this is 1 year follow-up of this patient, and this is the follow-up recently follow-up of 3.5 years, where I performed PK plus ECC PCIOL for this patient with regaining of very good visual acuity. So with the strategic treatment, we can gain a very good outcome for even for very worst complication. Thank you very much.
Thank you, Bhupesh. I think you've not really left too many questions, but we do know that Dr. Namrata Sharma has also managed these cases. Dr. Namrata, would you please?
I just want to know what antibiotics you use, the same protocol that you have been advocating, linezolid topical and
yeah.
And so actually, I have a feeling that it's kind of a confused management, because some people, what I mean to say is like you are advocating antibacterials, and then there's a paper which is published by Arvind who advocate antifungal therapy, and then there's a paper published by SN which says that cryotherapy and surgery. So we've got confused in all 3 of them. So of course, your case was managed extremely well and a great presentation into insights of Pythium keratitis. Guttering, like you said, is very important feature. Reticulated pattern or those tentacles, again, very important. I think now, even if we see guttering and reticulated pattern, as you showed, we just, we are very preemptive that it might be Pythium keratitis. So I think the treatment part still needs to be, clarified further, because antibacterial vis-a-vis antifungal vis-a-vis surgical.
So based upon the Arvind paper which you are quoting, the response is same as the Taiwan paper or Thailand paper which I was quoting, though they also said that the results are almost nil. They almost every patient, more than 90% responded, needed therapeutic ketoplasty. So based upon our experience, the first paper in 2018, which we published, so 92% patient undergone actually therapeutic ketoplasty. But after that, actually respond only 10 to 12% patient needed therapeutic ketoplasty. The paper which is recently approved actually is explaining that strategic treatment, which I was trying to explain. And the Shankar group actually is actually trying to say that therapeutic PK along with adjuvant treatment, alcohol and cryotherapy, which they are trying, is actually helping for Pythium keratitis. But in that also, the recurrence chances are there. But in our patient, in our series, there is no recurrence even after going for therapeutic ketoplasty. Even out of 32 patients, only 5 patients grew Pythium after ketoplasty, which suggests that treatment is actually working. And now this has been confirmed by animal trials as well, because we have done animal trial for Pythium, and our third paper is on review. So maybe that also will highlight and confirm of the finding which I am trying to tell. So there is no confusion in actually in our mind that Pythium can be managed in this way and should be managed in this way, because this is the way it is behaving. Well, we have almost 160 patients outcome, which is going to be published soon. So probably that will also clarify the result.
Dr. Somashila, do I have a split second to ask a question to Bhupesh? I know we are running a bit late.
Yes, Radhika. Yes.
Yeah, so the only question I had to Bhupesh was that I totally commend you on the success that you have with the medical management. We've not really been that lucky in our cases. The question that I have for you is that these cases are PCR proven Pythium, or what did you base your diagnosis of Pythium on when you put them on medical treatment and this outcome came?
Yeah, so all these cases, we are not doing PCR now. So we are actually only seeing like smear as I showed, as well as zoospore production in all cases.
Thank you, Bhupesh.
Thank you very much, Radhika. Thanks, Bhupesh. I think that is excellent case. Thank you, Dr. Namrata, for discussing it, and Radhika for your comments. We'll move on to the next presentation, and Parikshit will help me there.
It's Dr. Aditya Pradhan, dynamic person from Calcutta. So we have all the Bengal contingent present in spite of the cyclone here.
If somebody is introducing, then yeah, he or she has to unmute. Yeah.
Dr. Aditya Pradhan is a young and dynamic cornea specialist from Disha Eye Hospitals, Calcutta. He's numerous awards to his credit. He has been Young Achiever Award, ISCARAS 2016, and also won Think Under the Apple Tree from AIOC in 2018. He is also reviewer for cornea and external diseases for Indian Journal of Ophthalmology and section editor for cornea for AIOS Times, as well as section editor for cornea for TJOSR. Over to you, Dr. Aditya Pradhan, please.
Thank you, sir, for the kind introduction. I'll just stop your screen sharing.
Yeah, I'll do that.
So I would like to begin my case presentation. Thank you, Somashila ma'am and AIOS Scientific Committee for the kind opportunity. So I have no financial interest in any of the products in this presentation. So this was a saga of around 11 months in all, starting from October 2016, when this gentleman of 65 years was residing in West Bengal, about 250 kilometers from the base hospital at Barrackpur. He was a farmer by occupation. He came with the chief complaints of diminution of vision, redness, and pain in his left eye. The history was that he had, while working in his field, he had a trauma to his left eye by a wooden stick 3 weeks prior. And he was treated by about 2 or 3 ophthalmologists. I was the 4th one. And all of them had done some form of microbiological workup in the form of corneal scraping and KOH stain. And he was getting topical as well as systemic antifungals before he presented to our hospital. The important point was no indigenous medicines, that is local treatment or steroids, were given by any of the prior ophthalmologists. And the interesting point that the right eye was lost due to a similar injury while working in the field about 10 years ago. And basically it was an empty socket. The eye had become thiazical. So if you go to the clinical picture, this was the presentation that you could see a total limbus to limbus corneal ulcer with a thick hypopion that is filling almost half of the anterior chamber with a very central dense infiltrate, which is also extended to the periphery. So the vision was only positive perception of light. And considering that the one-eyed status, the prior 3 weeks of treatment with antifungals, both topical and systemic, The decision was taken to undergo an immediate therapeutic keratoplasty in that left eye. Fortunately, the syringing was patent in both the eyes. The surgery was performed by me on the same day under local anesthesia. The diameter of the graft was about 12 millimeters and the lens was preserved on the table. This clinical photograph is at day 7 after the therapeutic keratoplasty. The uncorrected visual acuity was 1/60. The culture of the host corneal tissue showed the growth of fusarium. The species could not be identified. Along with that, the AC was well formed. There was a nuclear sclerosis cataract of grade 4. And he was continued on oral and topical antifungals along with cycloplegics, a broad spectrum antibiotic, and artificial tears for 4 times a day to reduce the irritation caused by the sutures. So this is basically a timeline starting from 1 month after the therapeutic keratoplasty, where we cautiously started the topical steroids. The IOP and the visual acuity were pretty stable. About 6 weeks after the therapeutic graft, we are continuing the steroids. However, at around day 60, that is 2 months after the surgery, the patient suddenly presented with a mild reduction in the vision and increased redness, which had subsided due to the steroids given earlier. But now the redness had returned on probing and prodding and some questioning. The patient did admit that he had run out of the drops since the past 1 week. And there was a focal endothelial scar, this linear scar marks on the cornea, which I will show in the next slide. So we stepped up the topical treatment, the steroids especially, and asked him to report. Again, he was lost to follow-up. At 3 months after the initial keratoplasty, the steroids were going on. There was focal pass in 2 quadrants of the graft. The density of the nucleus sclerosis was gradually increasing. With pinhole, he was able to see 6/60. However, the details of the fundus were not clear. Around 133 days after the initial keratoplasty, the process was ongoing. The patient was almost regular in his follow-ups and compliant with the drops. However, we were able to see that the endothelial morphology was not very clear. I do not have the specular photograph to share with you, unfortunately. But the cells, although they were seen, the machine was not able to count them, and the morphology was not very healthy. So in our mind, we were thinking that this patient would end up with a graft failure eventually, considering there was a small graft rejection episode earlier at 2 months after the keratoplasty. So we gave this option both to ourselves and to the patient that yes, he may end up requiring another keratoplasty with simultaneous extraction of the cataract and an implantation of the IOL. At around day 214, that is almost 7 months after the initial keratoplasty, the vision was dropping, the cataract density was increasing. However, due to severe financial constraints, he was not willing to undergo for a triple procedure. And so we thought of that, okay, let's go just ahead with the cataract surgery and the IOL, and then do a DSEC or some other form of keratoplasty later on if needed. The patient and his relatives agreed to this thought process. So yes, this is day 214. As you can see, the cataract density has quite gone, and these are the linear endothelial scarring I was talking about in one small area of the graft. And so the patient was awaiting cataract surgery. Yes, the endothelial health was doubtful, but considering the limited choices for visual rehabilitation, especially was one-eyed, so we did decide to go ahead with the cataract surgery. Here I would like to emphasize that I did refer this patient to a colleague of mine. He is Dr. Arup Bhoming, a very senior cataract consultant at our hospital, because the density of the cataract and my surgical expertise as a cataract surgeon were not in tandem. So I decided that this has to be taken care by a very senior cataract surgeon. So as you can see, he did go undergo cataract surgery with a single piece hydrophobic IOL. On day 7 of the cataract, the visual acuity with pinhole was 6/18. There was, as this endothelial scarring as mentioned earlier, he was on steroids, a broad spectrum antibiotic and artificial tears. We could see the fundus very clearly for the first time after the keratoplasty. It was very healthy, and the IOP was also normal. So this is cataract post-op day 56, almost 2 months after the cataract surgery. Visual acuity of 6/18 with a minus 2.25 cylinder, and the drops and the steroids were continued. Everything was fine. Around 3 months after the cataract surgery, again presented with complaints of reduced vision and pain in 1 week. He was not seen by me, but another branch of the hospital by another cornea colleague. And the visual acuity had dropped from 6/18 to 5/60. There was severe graft edema, cells, flare in the anterior chamber. The working diagnosis was an episode of acute graft rejection. This would be the second episode. The IOP had also shot up, so it was managed medically. And the patient came back to me. This was 112 days after the cataract. Vision had dropped actually further. The reaction, AC reaction had reduced. The IOP had become acceptable, but the graft edema was persistent. We could tell that it was headed towards failure. So we planned a slow taper of the steroids and what had been discussed earlier, that is another graft for the patient. But the saga ends here. The patient did not show up after this, in spite of repeated requests over the phone and other ways to communicate with him, but it did not show up after this. So this is the end of the presentation. These are the learning and the discussion points which would, I think, be taken up by the moderators, that I had some questions and how would anybody else approach this case. So one is the history taking, one is
Aditya, I'll just stop you here so we can go to the moderators. Mainly here, I think more than the history taking, which everybody is aware of, I guess. But the second question you have is very interesting, the threshold of surgical intervention. So we'll ask the moderators for your talk to take over. Your case is to be moderated by Dr. Quresh Maskuti and Dr. Mahipal Sachdev, sir.
Yeah, so can I go,
yes,
Somashila?
yes.
Yeah. So I agree with Aditya. I also have a very low threshold. I would jump in straight and do for a one-eyed patient. I would do exactly what he did, a therapeutic PK. Points to be noted. Very correctly, he left the lens in place. Don't try and combine it with a cataract surgery in an infected cornea. Many people, especially youngsters, feel that we might as well get the lens out at the same time. Chances of endophthalmitis will increase. There could be a PC rent and things like that. So do one thing at a time. Coming to the second part of your talk, when you talked about the to do a DSEC triple, I would have preferred to do what you did ultimately. Just do in a one-eyed patient, go very slow, just do a cataract extraction. The point is you can always go in and do a graft later on, whether it's a DSEC or a DMEC or whatever it is. So your case has been managed exactly as you would and as you've done so far. And it's a tragedy that he hasn't come back to you. Otherwise, I think by doing a DSEC now after a second graft rejection, you could have again brought him to 618 or better. Mahipal.
Yeah, thank you very much, Quresh, and thank you, Aditya, for a nice presentation. Actually, as Quresh said, I would agree totally with him that the management has been done as per what was expected. The first thing is that if you have such a huge fungal load and you have something not responding to medical and systemic therapy, as you were saying that that patient had already been on antifungals, and natamycin normally does not penetrate so deep. What RP Center, Namrata and other people have described as also from other centers, that is the injection of voriconazole, that would not have worked in this particular case because the cornea was tending to be very melty. So I would agree with you that under such cases, there is nothing that either form of therapy, whether it is topical, whether it is intralesional, whether it is systemic, is going to achieve. It is going to remain there, the infection, and it is going to spread, and then it could have become a scleritis, panophthalmitis, endophthalmitis, whatever it could have progressed. So I think you did the very wise thing, and obviously you have to take an oversized graft, and when you're doing such a large graft, so 0.75 to 1 millimeter oversizing has to be there. One thing that could have been done, I don't know whether you did it in surgery, is that at times we would prefer to do a slight peritomy to actually see the extent of the infection, the fungal infection, as to how much it has spread. At times also the hypopion can give you a false impression as to the extent of the fungal infection. So that also needs to be taken care of. Peripheral iridectomy, I would do 2 of them because it's a large graft, and as you said, pus, etc. has formed. In such cases which are large grafts, you definitely these patients would be definitely more prone to a graft rejection, because obviously you are nearer to the limbus and the vasculature and the antigenic challenge goes. What is important is that in such large grafts that you have, doing an endothelial keratoplasty is possible. When you are doing an endothelial keratoplasty, a cataract, if that was one of the questions, a cataract I would have done through a scleral incision, but if I have to combine it with triple procedure, that means an EK with a cataract, then I might have done a corneal approach, because it's slightly easier for the desec to be done through a corneal approach than a scleral approach. So I think overall, the only thing I would have maybe after the infection was not there, you started him on steroids, I may have kept him more aggressively on steroids for a longer period. And also after the cataract surgery, I would have kept him on steroids and cycloplegics for a longer time, because at times there are endothelial down regulators that are produced by the ciliary body in the form of 12R heat, 12S heat, etc. That down regulates the endothelium and the edema sets in. So I normally always prefer to keep the steroids post cataract surgery in compromised endotheliums for a much longer time, along with a cycloplegic and pressure lowering medicine along with that. And obviously you were giving lubricants. So all in all, I think you have managed the patient well, and nothing is lost. Even if the patient comes now with an irreversible corneal edema, you could actually go ahead and do endothelial keratoplasty with great success.
What about the question on role of cyclosporin tacrolimus? Is anybody using it for these?
Cyclosporin, in the first instance, when you are looking at it from a graft rejection perspective, normally the concentration, I think Arvind people manufacture it as 2% of cyclosporin, which is not very well tolerated. So the normal concentrations of cyclosporin in any case take about 3-4 weeks to act, and in any case in such large grafts they may not be of much use immediately, because the challenge happens pretty much in larger grafts. So people do use it, but it's not a something tacrolimus or cyclosporin is not something very established. I think the best is to have steroids, but in this case you can't give steroids because of the fungal for a couple of weeks. So cyclosporin in any case will take about 3-4 weeks to build up a concentration to it to act.
The tacrolimus does act a little earlier than the topical cyclosporin, but again, cyclosporin is more a steroid sparing agent. In such cases, like this, I would prefer the actual steroids. Nikhil has put a comment saying that oral cyclosporin could be used. I don't have any experience with that.
No, topical cyclosporin, we did a randomized control trial which had over 90 patients, and we found that it didn't work as prophylactically also for graft rejection and otherwise also.
I prefer steroids in grafts, yeah.
So, and topical cyclosporin as an adjuvant to steroid did not offer any extra, benefit or any benefit in terms of less graft rejection or less episodes. So in our experience, it didn't work at all, topical cyclosporin. Systemic cyclosporin, I think there are papers showing that it does, might help. So I would rather go in for systemic than for topical. I think I agree with Nikhil on that.
I think it's a psychological advantage that a doctor may have that I'm giving something, but I don't think there is enough evidence for us to say that they will reduce the incidence of rejection. I don't know if anybody has any other experience on that.
So Somshila, you have to unmute yourself. You're muted.
Thank you, Dr. Namrata. I think very good points made by all persons. Thank you, Dr. Maskati, Dr. Maipal sir, and Dr. Namrata for chipping in. And Aditya, excellent case, very well managed, and really you saved the eyesight, maybe restored it for this one-eyed individual. Parikshit, who do we have next?
Yes. No, thank you, Dr. Aditya. And now we have the second last presenter for today, Dr. Pranav More. Dr. Pranav, is from my city in Pune, but he's been trained in KEM Mumbai, AIMS under Dr. Titiala and Dr. Namrata, and later in Arvind Eye Hospital, Madurai. He's currently working as a cataract and cornea consultant in the Sahyadri Hospital and his own Ayush Eye Clinic. And he also is visiting faculty to 2 medical colleges in Pune and PCMC. So over to you, Dr. Pranav. unmute yourself and share your screen.
Yes, you're on, Pranav. Just just go to slide share.
Audible?
Barely.
To increase your volume.
The audio, please. Admin, please look into the audio.
Is that good now? Is that good now?
No, it's not good. Louder.
Is this okay?
Very good.
Yes.
Okay, okay. Good evening to all. Warm wishes from Pune. I wish to thank AIOS Scientific Committee and Dr. Somashila for having me here. It's a nostalgic feeling because I'm presenting a case after almost 12 years in front of my teachers, Professor Tityal and Professor Namrata. I hope they are a bit milder on me this time as compared to my good old residency days. The topic that I'm going to present is a case presentation on a young lady, 23-year-old lady who was diagnosed to have bilateral keratoconus. The right eye had a heel hydrops, 2 years old heel hydrops with a significant amount of scarring, whereas the only seeing eye which we had was having a moderate keratoconus, and I had offered her a coragen cross-linking procedure for the one. Her best corrected visual acuity in that eye was 636. There was no other predisposing factor, no systemic associations to have keratoconus. She didn't have any atopy. She didn't have any other systemic conditions which could cause secondary keratoconus. The procedure that I opted for was accelerated CXL with an epi-off. The procedure went off pretty well in classical aseptic precautions taken in an OR, and uneventful procedure. The patient did have some pain post-operatively, which is expected in an epi-off procedure. The immediate post-op, the patient only had a BCL in situ and no major complaints on day one. She was put on a routine protocol of antibiotics and lubricants in the immediate post-operative period. This procedure, which I did, was on a Saturday afternoon. And so there was a Sunday where the patient was seen by my resident and fellow initially. And they just reported back saying that the patient's pain has reduced and the patient is on a routine post-op course. So the patient was sent home on Sunday afternoon. And the patient had no complaints till Monday afternoon when the patient came back on day 2 with significant amount of pain. Ideally, post C3R, if the patient is on a BCL for 48 hours, the pain should settle down and the patient should be much relaxed, even if it's an epi-off procedure with the BCL in situ. But the patient presented on a Monday afternoon around with pain, significant amount of pain now, a lot of redness, quite an inflamed eye, and a lot of whitish lesions, which I'll show in the next slide. So this was the presenting feature on day 2. Quite ghastly to look at in a patient who has just undergone so-called not so invasive, minimally invasive procedure for a refractive condition like a keratoconus. And this is very ghastly. I almost missed my heartbeats there when I saw this in a post C3R patient. And looking at these are nice elevated gelatinous lesions. The central lesion pretty much restricted to the area of epi-off zone, and a very nasty looking lesion to see on day 2 in a post C3R patient. I was really worried. So obviously the epithelium had not healed off. There was an overlying ulcer defect. Scraped the patient, send it for a microbiome assessment. The attending microbiologist in the hospital reported it as gram-positive cocci. And therefore, this patient was started on as a normal empirical protocol without having a culture report, put this patient on a fortified vancomycin with moxifloxacin eye drop 1 hourly, hoping that this patient will start responding. We did send it for culture and sensitivity also as per the protocols. So I had to wait till the reports came in after 48 hours, which was on day 4. And the day 4, the reports sent to me by the microbiologist suggested that the patient doesn't respond to vancomycin. He doesn't respond to any of the fluoroquinolones. So the primary drug of choices that I put in for such a ghastly situation in a minimally invasive procedure were not going to work for me. So then I went through the report and it just showed that the aminoglycosides is one of the groups which is working pretty well or has an intermediate sensitivity. as compared to the ones which we had chosen, vancomycin or moxifloxacin. By day 6, I think day 5 or day 6, the patient walked into the clinic saying she's not feeling fine. However, we put this patient after day 6 on amikacin 2%, because as per the culture reports, the patient was started on amikacin 2%. As the time passed, we did notice that the patient was responding pretty well, and just taking some anecdotes or taking some inspiration from the SCUT study performed at Arvind Eye Hospital, I decided to introduce a mild surface-acting, low-dose, low-potent steroid in the form of loteprednol, itabonate. And this, I started at a frequency of 3 times a day for the first 3 days, but I did keep this patient on a close follow-up. The epithelial defect had almost heal, but there was a significant amount of scarring and an inflammatory infiltration going on in the cornea, for which I then decided to put this patient on loteprednol on day 14. The response that I actually noticed after introducing loteprednol was quite impressive, and the scarring from the first day 2 image to the day 21 image, it just clearly says that introducing steroids at the right time have helped in a situation, a sticky situation, a nasty situation like this, to salvage to a point there wherein by day 40 I had a scar which was barely minimally visible, not significantly hampering the visual acuity. Uncorrected visual acuity at day 40 was around 636, which along with the scarring, I thought was rather a more reparative and much of a respite for going through a post-operative infectious keratitis in a C3R. So quite a scary situation to start off with, but shouldn't lose faith in managing it, sticking to the protocols, going by the medicine, going by science, playing around with it, altering things as per the reports come up has helped, and making use of scientific research that has been provided to us through so many research trials has actually helped recover this outcome for us in a situation which looked very nasty and ghastly in a nearly one-eyed, I wouldn't say one-eyed, but nearly one-eyed patient, a young woman with just a keratoconus and undergoing a C3R procedure. The thoughts that I had on my mind was epi-off. So there has been an epi-off versus epi-on debate for a long time. Either of it are efficacious in terms of managing progression of keratoconus, but having a look at this kind of a scenario, you generally don't want to see something like this. An epi-off versus epi-on was something on my mind. Should I switch over to an epi-on procedure pattern? Is there a good time to start topical steroids? What would be a good time to start steroids? I usually would start topical steroids on day 3 after the BCL is off. Even if there is a minimal epithelial defect, I would still choose to put a low-dose surface-acting loteprednol kind of a molecule. And has anyone encountered a scenario, because I was going through the literature then, there are only 10 cases published worth considered as post-C3R infectious keratitis. There were 50% of them bacterial, few of them were fungal, and 2 of them were Acanthamoeba. 1 or 2 odd were herpetic. Has anyone encountered a ghastly scenario like this of C3R, wherein probably sometimes you might have to, like in Acanthamoeba, where you want to do it as early as possible? Anyways, DALC is one of the considered procedures for keratoconus. So I was just wondering if anybody would have thought of doing an LK, early LK, if this was not going to be responding or recalcitrant.
So thanks, Pranav. We'll go to the discussants, Dr. Namita Sharma.
I think I'm proud of you. That case was managed very well.
Thank you.
It is almost miraculous. Having said that, to answer your questions, epi-off versus epi-on is on related risks. You did the right thing. I think epi-off is the way to go, because epi-on is not that efficacious. And good time to start steroids. I think all of us now agree with the infiltrates that you get sometimes after collagen cross-linking. It is the day 4 or day 3 whenever the BCL is off and epithelialization is complete. And I think that was the correct way of doing that. You first saw that whether it is responding or not, and then take a subsequent decision on the surgery. We have done, at least in my memory that I can remember from anecdotal cases, that we've had about 4 keratoplasties, which were LK 50/50 and PK both. And I think the case was managed very well.
Thank you so much. Thank you. Thank you.
Dr. Titial, your experience on this particular entity?
Yeah, I think, Pranav and Namrata have done very well. I'm very happy to listen to this. And we know that, infection after CXL is not uncommon. People do see such cases. And as Pranav rightly pointed out, it's really, heartbreaking sometimes to see a healthy keratoconus patient developing infection after 2-3 days, and your entire outcome goes haywire in such cases. I think a few things are important, because once we do a epithelial debridement in these cases and get all the defense mechanism of cornea to a rest, that means you have total loss of keratinocytes. The entire cornea is like a growth medium for these bacterial growth. So you have to be very careful to begin with. Do a proper asepsis for these patients. Maybe give an antibiotic cover. Do a betadine wash for a longer period for these patients. And proper OT environment should be must for these cases, because these are like intravitreal injections nowadays. So if you have something going wrong in these patients, you had it. So some precaution has to be taken, and we know that infection can occur. So timely management, as Pranav showed in this particular case, is appropriately important for all of us. And getting a culture report and having a sensitivity in your hand, seeing early response of medication. The steroid ad was very nicely done in this particular case. So people say, when should we start steroid in all these infections? As soon as you have a patient under your control, that means you can see the patient regularly, you have a culture sensor in your hand, and you feel a response is coming. And that's the time in bacterial infection you should start steroid full dose. And that will decrease the scarring in such cases. And I think, appropriate management should be done early in these cases, because sometimes we don't see patient in the right time, and that can create a problem. And mostly it's a bacterial infection in these cases, and I rightly said some fungal Acanthamoeba can occur. And some young patient with the viral reactivation is one of the major challenge for all these patients as such.
Thank you, sir.
Nice case presentation.
Yeah, very well presented, Pranav. Thank you for sharing this, as you said, devastating when you see the patient coming in like that. Thanks, Dr. Namrata, for your valuable inputs. I think we'll move to the last presenter.
Yeah.
So the last presenter is...
I think, Somashila, you are introducing Dr.
So let me introduce Dr. Radhika Natarajan. She is the Deputy Director, Department of Cornea and Refractive Surgery, and Head of the Department of Teaching and Training at the Shankar Nethralaya, Chennai. And she has 25 years of experience of being a clinician, researcher, a student mentor. And she has to her credit several books which she has authored and co-authored. Her basic areas of interest are corneal infections and inflammation. So over to you, Dr. Radhika.
Thank you for that kind introduction. Hello all, I'm Radhika from Shankar Nethralaya, and special thanks to Dr. Somashila and the scientific committee for having me here. I'll share my screen right away. Can you see my slides?
Yes.
Can you see my slides, and am I audible?
Yes, we can.
Yeah, okay. So the last case and my presentation for today will be a case of Xeroderma pigmentosa. So Xeroderma pigmentosa, we know, is a rare autosomal recessive disorder. But it is important for us cornea clinicians because many XP patients have corneal problems. And basically, when ultraviolet light damages DNA in the cells, normal cells are able to repair that. But due to an enzymatic defect, XP patients are not able to execute that repair. And the nuclear material gets strewn about in the cells, and that induces malignant changes in epithelial cells. Apart from widespread cutaneous involvement in the exposed parts of the body, the other important site of involvement seems to be the corneal limbus. And because of this, these people get epithelial problems like SPKs, epidefects leading on to corneal ulcers, and the limbal instability also causes ocular surface tumors. All these were seen in my patient of Xeroderma pigmentosa, who was also a single-eyed patient. So basically, he was a 45-year-old male patient. He was a known case of Xeroderma pigmentosa. He had multiple hyper and hypopigmented macular papular lesions in his face and his arms. He had a couple of those big black lesions on his eyelids as well. And he was on photoprotective treatment when he presented to us. One eye, he had lost to corneal infection long back. And in the second eye, he had undergone multiple procedures, which included a couple of keratoplasties and a cataract surgery, all of which were done elsewhere. He came to us with acute reduction in vision in his only seeing eye. And this is what we saw, that there was a large and deep infiltrate in the corneal graft, limited to the graft area itself. Also noticeable were two small areas, nasal bigger than temporal, two areas of keratinized OSSN-like lesions. However, we did not know whether they were just dysplastic lesions or whether they were actually invasive carcinomas. We did a corneal scraping, which came positive for Aspergillus flavus, and we started him on 2 topical antifungal agents in the form of natamycin and voriconazole eye drops, along with supportive medication. The culture also showed fungus. Unfortunately, he did not respond at all to the medical treatment, and we were forced to take him up for therapeutic penetrating keratoplasty. We did a large TPK graft, and also we did an excision biopsy of the suspected OSSN lesions. We gave a wide excision margin, and we adopted a non-touch technique to avoid spilling of seeding over of cells inside the eye. And we also did a cryo application freeze thaw technique to the edges. And we continued the topicals post-operatively. The corneal button also grew fungus, and histopathology showed invasive squamous cell carcinoma with reasonably clear margins. Post-operatively, the corneal graft, under very close watch and plenty of lubrication, did epithelialize completely. You can see that in this picture over here. And the post-operative period did not show any recurrence of the fungal infection or recurrence of the small OSSN in the excised sites. However, 3 weeks later, when the patient came to us, as you can see in this picture over here, he developed multiple whitish patches, leukoplakic-like lesions, especially on the eyelid, which you can see in this picture, and also in the nasal and temporal conjunctiva, which you can see in the picture that I'm going to show you next. So we were wondering whether this was some kind of recurrence of dysplasia that is happening in a site that is different from the previous excision. His systemic workup under the care of an oncologist came out normal. And the oculoplasty colleague wanted to actually take biopsy from the lid to look for evidence of malignancy. Then we figured out that the patient was on voriconazole eye drops, and voriconazole drops as well as systemic voriconazole are prone to cause dysplastic changes. So we went easy on the drop, we stopped it and continued natamycin alone. And you can see in the picture below that the whitish patches in the leukoplakic changes on the lower lid have disappeared completely. So the points to ponder in this case were Xeroderma pigmentosa, it is better not to do a keratoplasty, but if it had to be done, the primary surgeon who did the PK, would they have been better off doing a limbal support procedure along with the transplant? We had an in-house debate and we thought no, because these limbal transplants have to be allogenic and they would require immunosuppression. And in a disorder which is already so prone to malignancy, it would not be a good idea to give prolonged immunosuppression. And it's really not all or none. We saw that the therapeutic graft did epithelialize over a period of time. So we could do the PK, wait and see. If there is a hint of persistent epithelial problem, we could jump in and do an alloslet or something. We have Dr. Sangwan's paper on it, which I have referred later. And the treatment of the OSSN itself, when you have a corneal ulcer needing a TPK, do you want to give topical chemotherapy? Because in the presence of an ulcer, also these are very toxic medication. Already this epithelium is an unstable epithelium, so you don't want to use these drugs. But at the same time, doing a surface excision along with an intraocular procedure also carries the risk of seeding, which till now has not happened in our patient, but we are keeping our fingers crossed. And lastly, voriconazole also leads to dysplasia, topically and systemically. It is a photosensitizing effect which leads to dysplasia, which is very much same as the photosensitizing dysplasia caused by the XP as a disease itself. So probably this drop should not be used in this disorder at all. However, our patient also showed, and reports also show, that voriconazole-induced dysplasia does stop with cessation of the medication itself. So in XP, limbal support or not with PK, OSSN surgery and TPK surgery together or not, and voriconazole or not. So the expert panel, please share your opinion on these.
Can I come in, Somashila?
Yes, please. Yeah.
Yeah, excellent, Dr. Radhika, very well managed. It's a very difficult case in a one-eyed patient. One of the biggest learnings from this is something that I myself didn't know till you sent me this, and I did read up on this, of the effect of voriconazole on causing these heaped up lesions on the lid. And otherwise, I would have sworn that this is requiring a lid biopsy and would never have suspected it to be due to voriconazole. So that is a big learning for me, and I'm sure it's for the audience as well. And your take-home point is that voriconazole does have this side effect. I would agree with you that there were risks of doing an OSSN procedure along with the TPK. On first thought, I would have just done a TPK, and the OSSN is not really vision threatening, or you could have waited for a month or 2 months and then done the OSSN. But as you did it with a no-touch technique with a triple freeze thaw, the chances of seeding are not very great in this. So I think what you did, it's a one-eyed patient. You don't want to keep on doing surgeries. Right. So what you did is correct. With a no-touch triple freeze thaw technique, you did come to the conclusion you could get a histopath and know what you're dealing with. So I think there's a lot of learning points from you asked some questions, but more than that, you've given us a lot of answers on how to manage difficult conditions like this. I have done 2 patients of XP with a Boston K-Pro, but that's without any infections, just with failed grafts in these patients because the grafts don't do so well. Optical. So instead of doing another optical graft, I've done a Boston K-Pro. That seems to have done well now, about almost 9 years follow-up. But that's different. But for a patient with infection, which is one-eyed, I think excellently managed. Compliments.
Thank you so much, sir. I would also like to ask Dr. Sangwan about his opinion on Allosled as a primary procedure along with the first PK. I mean, would immunosuppression be a good choice in this kind of a patient who's already prone for malignancies?
So Dr. Sangwan had to leave, so he's okay here. And the question on Allosled, I don't know, Feroz, if you had a chance to listen in. So this is a case of OSN. Have you done any Allosled for these patients? Because yes, this was an OSN at the nimbus and a large PK was done. So
yes, I do have experience with Allosled. If it is a large tumor which is occupying more than 180 degree of the limbus, in fact, we really don't want the limbal stem deficiency happening. So yes, I have just done 2 so far, not too frequently done, because now that we have topical chemotherapy, so we try to reduce the size of the tumor, chemo reduce or immunoreduce the size of the tumor and then go for a limited excision. That's what we do now. Excellent case, and you have managed it so well, ma'am. So yes, very learning, quite a learning case.
Thank you so much. Thank you, Dr. Maskati, as well, and thank you so much.
Thank you.
Is there anyone else who would like to add to the discussion for this case?
Good. So, Dr. Somashila, can we come to the end of it?
Yes, I think it's been a long journey. Although we couldn't stick to time, apologies for that. But I'm very, very happy with the way this whole meeting went. And we had some excellent presentations, both by our international faculty who were very kind to give their time, which is early morning for them, and spoke on 2 excellent topics, covered it very well. And also, I'm so grateful to all our presenters who took out the best from their cases, most difficult, maybe very difficult to manage. Not everybody likes to show that they couldn't manage or the patient had this particular outcome. It was very brave of them to present those cases and to discuss with us and teach us about the difficult management points in those cases. I'm grateful to them. And also grateful to Dr. Partha Biswas, grateful to Dr. Namrata Sharma, Dr. Mahipal Sachdev, who have helped us put this together for the scientific committee. As all of you know, this is our first webinar. And all my buddies on the scientific committee who have been with me, Paritosh, who's my co-moderator actually, so he deserves all the thanks and support from me because he has just been supporting, doing everything in the background. So if I've forgotten anyone, Paritosh, please chip in.
Parikshit.
Parikshit.
Soumashila has been so busy in managing the webinar and getting everybody together. So she's the one who needs a drink actually, at least a lemon juice.
Please take permission that I'm going to call you something.
Dr. Somashila, you vanished on us.
Sorry, I don't have any electricity right now.
Okay.
And thanks, of course, to all the attendees who really sat through. I actually messaged them earlier because I knew they might leave. Thanks to the tech support with Sai and his team and the webinar. And of course,
very good.
has helped a lot in everything by managing all the different social media for us.
And thanks to Dr. Partha for putting us all to work and getting us all chip in and do it. Thanks a lot, sir.
Thank you very much. Sir Quresh, sir, any last comments from you, sir?
No. As I always enjoy a good cornea session, so I really enjoyed this one. Lot of learning for us as well as it's not only teaching, it's learning for every single person who was there on either side of the fence.
Agreed.
So thank you, Partha,
Wonderful
for organizing an excellent cornea meeting.
Thank you, sir.
Thank you, sir.
Thanks to the panelists and presenters. Fantastic presentations, mind-boggling. We've had very, very good comments and very appreciative comments from our viewers and also from the faculty. Thank you very much, and thank you, the scientific committee team. It's really a wonderful way of doing things, and even so late at night, all of us are there with you. Thank you. Thank you.
8 p.m.
Thank you. Bye-bye.
Bye.
Thank you.
Thank you, Dr. Somashila and AIOS Scientific Committee.
So
Yeah,
are we
thanks a lot.
off air now?
Keep doing this continuously.
Sai, are we off air or still?